Okay, cool. We're live. Ready to rock and roll. Okay. All right, guys. So, if I could, for favor, have your attention. Jeez, that's hot. That's not too bad. I guess is that this a little weak? No.
Probably not.
It's normal. Easy drinking coffee, yeah. So we gotta get coffee next. Basically looking at me like, what in the world? I don't have liquor in here.
Never drink coffee a day in my life.
Good.
Oh, really?
Do it. Just don't start. Yeah.
So, anyway, so I wanted to say you all have done a fantastic job. Hopefully, you don't screw it up with these presentations. That's easy. You guys are gonna do great. No pressure. Zach's over there like, oh my God. You guys are doing great. So, as you know, as we've been going through, I've seen you all really put forth the effort. I think that there were times when you guys kind of slacked off a little bit, or kind of got didn't put as much effort in. It was kind of evident in some of the presentations, but overall, you guys have done a really, really good job of sticking with it. I think that sometimes students, especially when they're nearing the end of the program, they're starting to get ready to apply to professional schools. What'll happen is that they will just, what'll happen is they'll get distracted or whatever else, and they won't pay as much attention to this course, and it'll cost them. They'll end up with a B instead of an A, or a C instead of a B. So you all haven't done that really this semester. So thank you so much for continuing to put forth the effort. Thank you for allowing me to lead you through this course. This is a course that is heavily actually led by the students. So as I mentioned, the first class, if everything goes well, I'm really just kind of on the side. I don't really have all that much to say, because this course is really one that is led by the students who all have done a fantastic job doing this. So you should be definitely proud of that, and then also building up skills of presenting in front of the class. It's not an easy thing to do, to get up here and to basically lecture your classmates and your professors in the back. It can be very intimidating. Some students will begin with being absolutely terrified, having stage fright, and not really knowing what to do. And by the end of it, they've grown. They've definitely progressed. Now, maybe they're not some great orator that will give many long speeches, but they are more confident. They've gathered and garnered skills, honed their skills for times when they're going to interview in front of a panel, when the panel asks them questions that they were not prepared for, right? All of this is to sort of get you to be able to think on your toes. And hopefully we've been able to establish some modicum of that skill set in your repertoire of ammunition that you'll take when you go into the world. So we are always here. The physiology department is always here if you need us. If you need anything, and I'll say this again on Friday, but I'll make sure I get it out right now, just so that I don't forget. And I know everybody's gonna be worried about the final on Friday, but excuse me. The physiology department is here. Your professors are here beyond the scope of just you being in this course. We want you to know that you have got someone who will help fight for you, that will really sort of back you, whatever decision that you choose to go. If you want to be a stay-at-home mom or dad, we fully support whatever decision you make, right? If you want to go off and be an oral surgeon, if you want to go off and be a dental school, professor, whatever it is that you want to do, if you want to become a nurse and you think, oh, well, I'm settling because I really want to go professional. No, like in hindsight, like nursing is an amazing degree that I probably would have taken a lot closer look at had I known what I know today. Like nurses, you come out, you start making 60 to 70K, you work 3 12-hour shifts, and then you have 4 days off. And guess what? If you want to work more, you can work more and earn a lot more and still, maybe work only 4 days a week. So there are options for getting past it. If you want to go get your DNP, your Doctor of Nurse Practitioners, those students, I know someone who came out of that. You go to nursing school for 2 to 3 years. You go to the DNP program, which is 2 to 3 years. You come out making 105, and the hospital that you work for, you can negotiate in your contract that if you stay with them for 4 years, they pay off 100% of your student loan, undergrad and grad. So there's a lot of stuff that you guys have out there.
In terms of the nursing programs, though, if you go into that and you don't have a degree for nursing, you have to go back and do the normal nursing degree, or what? How does that progress?
Some programs only require prereqs. You don't necessarily have to have a bachelor of nursing. You can just have the prereqs, and then as long as you have all the prerequisite classes, you can apply and you'll be fine. And especially because you all are at the master's level, you not only will most likely guaranteed get accepted in a lot of these schools, but you will be the lead student in there. Like you will be the top of your class. You will be doing extremely well. So whether it's that, whether it's MD, whatever, a DO, right, physician's assistant, there's so many opportunities out there. And I've seen a couple of students that have applied, that they've got in their mind, I've got to go to med school. I've got to go to med school. That's what I've told my parents. That's what I've had in my mind for a long time. And they're so focused on med school that they don't realize that there's so many other opportunities out there for them to get the same satisfaction of helping in a clinical setting, helping a person that will give them a very similar style of living as well in terms of monetary compensation. But half the responsibility, half the stress of that. Now, they've got in their minds, they keep trying. We have the student here who's applied for like the third or fourth year in a row. We don't see many of those. But if that's your goal, then you definitely stick with it. But I just want to let you know that there are so many opportunities awaiting for you that you would be all amazing at, that are at your fingertips right now, that you could apply for, and with your record, with successful completion of now your master's in physiology, you guys would definitely, all of you, do great in those positions. So just keep that open. If you'd like to talk with me more about that, I'd be more than happy to do that anytime. Stop by my office anytime. If it's in the fall and you're just by campus, hey, swing by, say hey. If the door's closed, just knock, right? I'll open it if I'm there. If I'm not, obviously, just slide a little note or something underneath the door, like in second grade or something. But yeah, stop by and say, hey, I've got a student from last year who actually, multiple students who stopped by this past spring. It's really nice just to catch up with them. We'll have some, donuts, if there's donuts or coffee or something else. Maybe it's like, you guys have donuts all the time? No, I don't have donuts all the time. But so anyway, that is sort of the little spiel. It's been a pleasure. I hope that you all keep in contact. I wish you all the best. And I think that's pretty much it. You guys have been great. So yeah. All right, guys. So donuts are over there. Please eat them till they're gone. So yeah, you're gonna have to do that. That is a chore you're gonna have to accomplish, right? Coffee over there, coffee mugs as well if you want some. Feel free to get up and go over there anytime. You don't have to wait till like an intermission. It's not like a play. And I think that's it. Does anybody else have any questions, comments, and remarks? I will be updating as much as possible grades today, so that really the only two things left are your final presentations, which is today and Wednesday, and then your actual final. So everything, I'll make a bunch of columns. That's on my number one thing to do list. Thank you for sending an email. I'll get to yours as well.
Yeah. I would like to figure my situation out. So we can talk about that.
Yeah, we do. I don't actually think. Yeah. So. Yeah, you're still not registered for the course, and so that's, I don't know why, but so come talk to me, and then Denise is actually out today, so I think she'll be back tomorrow or Wednesday. So we may, there's nothing I can do on my end. We have to get the administrative, and they've already told me that you've resolved the issues on your end. It's just now it's in sort of litigation, if you will. Yeah. So we've got to get that, because I don't even think I can see you on Blackboard.
No, yeah,
So keep on us about that, and then yeah. So I'm sorry about that. It's not.
It's not me ultimately.
You got 4 days.
Yeah.
So yeah. Well, no. If you complete the course, you complete the course. So any questions, comments, fun stories of weekend escapades that anybody wants? Arnie, go ahead. Yes. You had a dream about Alex.
Oh my God,
No way.
Yeah. it
Was
scary.
he like, what was he
So,
styling? Was he like
there was this old lady that
Magellan, like Magellan? Remember
there
those
was
old shoes?
this old lady that lived next to me who died. So we don't know how, but we were
Alex
going in there to clean up after her, and she had like this digital frame, and that picture.
Alex was in the old lady's house? Alex, portrait was in the old, is that, I hope that's not embarrassing. I don't really want to embarrass anybody.
Like,
That's awesome. Did you wait? What? Alex is a cool cat.
Because it had something to do with his picture.
What about
She
it?
died.
He's a cool cat. Alex.
oh, Alex's picture caused it somehow.
Yeah.
No, Alex is a cool cat, man. Shoot, if I saw Alex's picture framed like it was with a hat and like the thing, I would totally
Not
frame
even
that and
great.
put it in my office and I'd be like,
Alex,
that was one of my previous star students. And in fact, when Alex goes to med school and when he gets through, he's going to be like a cardiothoracic surgeon. That's what he's going to be. He's going to be a cardiothoracic surgeon. And when he's accepting this award, I'm going to be like the random old dude, kind of like sneaking up there on top of the podium and be like just a microphone. Well, who's that guy who did that to Taylor Swift? The T Swizzy? Kanye. I'm gonna be like Kanye coming up there and be like, hold on 1 second, right over here. And I'm just gonna hold up the picture. So it's I'm gonna be like, you a boy, Alex, you a boy. Anyway, so yeah, that picture. I hope that's not too embarrassing. So anybody have any? Let's okay. We don't want to pick on Alex. Anybody else have any dreams about somebody else or? That's awkward. I don't need to. You don't have to answer that. That's probably like HIPAA regulations that I'm violating right there.
I watched a bunch of classic movies that I was
watched
watching
classic
them
movies
growing
too.
up. So I'd never seen Silence of the Lambs.
Oh
The
gosh,
Matrix.
no. Wait.
That one.
You've never seen The Matrix?
I know.
Matrix is
1999 was the year. Y2K was on the horizon. What's Y2K stand for, y'all?
The world.
No. Year 2000. What? Crisis. Even though I know. That's the funny thing about it. Y2K was gonna hit. Everybody's like, oh my gosh, computers are gonna, go crazy and stuff. So I went to go see The Matrix in theater 3 times. It was like, what if we're in the Matrix? It was like
I own all the Matrix.
it was pretty intense. So you saw those. See, I thought you were talking like Swiss Family Robinson.
Oh no, I've seen.
Well,
these are ones I was
Gone
allowed
with
to
the
watch
Wind.
Growing up because they had gravity stuff, and I'm like, I'm grown and not influenced easily anymore. So let's watch that.
That's cool. Good. Yeah, that's a great lineup. Anybody else have any other cool movies?
I love it.
When the Matrix came out.
You were 2?
So was I.
Seriously?
Yeah, we're
I
the
was
youngest.
4.
Yeah.
I feel like an old dude. Man. But I don't feel like an old
You
dude.
were 30. Jules, how old are you?
A P90X will make you young.
Jules. What'd you say? How old are you? 22.
Wow, really? What, are you the youngest? Who's the youngest?
He's younger. Austin's younger than me. Yeah.
What are you gonna drink? He's old.
You can drink a beer whenever you want.
And Zach takes the cake for the other end of that spectrum.
I don't like lipstick.
Don't embarrass him.
He's like 76.
No. Any other fun things over the weekend? You got some street, you got some gray.
I got the gray skirt.
That if I still had hair, ooh, I didn't show you my hair, but I gotta show you that after
Yes.
before the final.
Did you have your long hair when you went to go see the Matrix?
Yeah, yeah. Wait, what was the Matrix? I was in
99. You said.
so 99. Yeah. Man, that was a good
I
movie.
googled Keanu Reeves a lot while watching it.
Keanu is a cool cat.
He has so much more hair.
Anybody else have any other cool story? I watched The Black Stallion from 1976 over the weekend with my family because we just finished reading the book. We do audiobooks in the summer. We have like summer of reading, and so it's a really, really great book. It's a really, really good book. So, any other?
Does anybody know what revisionist history?
Say it again.
The podcast?
Revisionist history?
Yeah, Glasgow.
Yeah, it's really, I
Yeah.
listened to one this week. It's really, really good.
Another fantastic podcast that I just found is called Smarter Every Day.
Oh,
It is such a good podcast. This guy's got he's an engineer and he's just an everyday Joe. And he's like, well, why does that happen? And so, or why does this happen? He's got like this super like 30,000 frames per second camera that he can actually. There's something called Prince Rupert's drop. And supposedly, if you take molten glass and you drop it in a bucket of water, the drop that forms is almost like it's impenetrable of glass. If you take a hammer to it and hit it, and it won't shatter. You can actually. He actually showed that he fired a .22 caliber bullet at it, and the Prince Rupert's drop actually it ricocheted the bullet. Because of the structure, because of the way that the glass cools, it actually cools on the outside first, but the inside is still hot. So it's, I digress. You're gonna have to watch the podcast. It's really, really cool. So Smarter Every Day is a fantastic one. I get my news from this kind of like edgy person. A lot of the news is called Philip DeFranco. Anybody know Philly D? So I listened to Philly D's. I didn't like him. I didn't like him 7 to 8 years ago because I'm not one, to drop the F-bomb every day and so he was a little more edgy with the language. And so I was like, man, I'm not gonna, but he's definitely mellowed out and gotten more news focused. So I listened to him. That's a great game. You want me to show you how to cheat on that?
Yeah.
I actually got up to 750.
Oh, one of the doctors at work has like 1,000 something. I don't know how he got it.
I'll tell you how to do it.
Okay, let me know. Yeah.
What is it?
It's the game, the balls game where you break the bricks.
PALOZ.
PLOZ. Yeah.
Anyway.
It's as big as the map is ER. While we wait for
Any other questions, comments, and remarks?
lab work.
No, I know I'm delaying it, but I'm delaying it because I like spending time with you guys. Like this is fun for me. Well, I can't join you. I can't join you for beer on Friday. So I'm sorry, but as a professor, you can't mingle with the students. Okay, cool.
Okay, wait a minute. What time on Friday? Because we're done at 11 a.m. on Friday.
Let's start then. Drinks at 11.
Artie,
We're gonna go play racquetball on Friday. Does anybody want
racquetball right after the beer, right? No, I'm just kidding.
That would be a disaster.
It was like 10 years.
If we get enough people, we can.
All right, guys. Well, Eddie, you got a story? You made eye contact. You got a story?
I went to a graduation party on Saturday.
Woo woo! Did you slap him high five? Awesome. It was the best. You know the high five originated here in Louisville? Can you believe that? In 1970s? It was actually, I don't know the full story, but my brother-in-law who is a basketball thing. Yeah, it was a basketball thing. He was an aficionado. It actually began, the high five became something at you, but like that's when it first began. If that was a viral video, it totally would have
We have
viral.
some of the weirdest claims to fame.
Yeah.
Disco ball.
Disco balls. No, what? Louisville?
Yeah,
I heard that one too.
like we still like are like the official seller.
Wow.
I believe we are.
making huge disco balls. That's what I heard.
You know what I heard? Sheep and cattle.
Sheep and cattle.
Me too.
Caleb got it. You know what I saw? You know what I saw? Logs. Did you get it? You guys get those daddy? So you can do that to anybody? Oh, there it is. Like, you know what I heard? Iman, what did you do over the weekend?
We all hung out. Me, Auntie, Alexis, we all hung out.
That's a cool kid group. I was never part of that group.
No, we're not. We're pretty lame. And then, yeah, studied for the DAT. That's pretty much it.
That's the word. Weightlifting shirt. How's that?
Yeah, it's a really old one. I haven't done laundry in a while. It's from high school.
I didn't know Trojan was a weightlifting.
Oh no, that was my high school mascot.
What's the
It's
Trojan?
the shirt. I'm out of clothes.
How was your weekend?
It was good.
That sounds good. It was good.
It was good.
Anybody else want to say something to delay us beginning? No? Okay. Julie, green.
Killing it,
fingernail
killing it.
polish?
Oh yeah, it was for Bonnaroo and now it's disgusting. I really need to take it off. But I just want it to linger.
Well, he was trying to compliment you, but.
Gonna say, wow, that
Everyone's
looks
like,
great.
some
You're
people,
oh, yeah.
you either
It's
like it or you don't.
somebody vomited on my fingernail. It's like vile.
It really does look kind of weird. But context of honor, it looked good.
I'll take your word for it on that one.
Interesting.
Yeah.
All right, guys. Well,
That you witnessed me purchase.
right, what else is there? Oh, right. So the remember that Friday we'll come in. I'll give you guys that survey. I didn't give you the Zoom survey because I'm just gonna put them all together. That way we don't have the end of the course survey and the Zoom. It's just gonna be all one survey. That way you don't have to take two surveys because you can have survey fatigue. Because I'm sure you'll be getting some of those through admin.
What's the mechanism of that?
What's the mechanism of survey fatigue? That's a great. We do need to get started. So, Macy has a question.
You didn't forget me on Thursday, correct? Thursday, I'm taking time.
Yes, I'm glad you are going to send me an email about that. You told me about that, and you talked to me. But you would be greatly esteemed in my eyes if you sent me an email to remind me that. I was trying to make that sentence work. I probably should have started. Hey, please send me an email to remind me. And then what time did we say on Thursday?
Hopefully early.
Right.
He sounds convinced.
You bring the donuts, and I'm just kidding. Yeah, so talk to me after class, or send me an email, we'll look up the time. Okay? Anybody else have an issue or a conflict with the final? No? Okay. All right, guys. Well, I'm going to abdicate
Who's going?
my role up here in podium.
Who's going?
No, oh God.
You can do this. Hey, no.
Wait, turn it so.
No, wait, start it again. So I'm sorry, I checked this one. Wait, no. Oh, snap. How do
Does mine, what kind of phone do you?
I? What are you doing?
Now I'm gonna, if I can't do
How
the
do I?
trick, I'm
How
gonna
do you?
wait, yeah,
How do
here.
you? How do you get it to where you see all the apps?
Double click the.
All right, so group one, come on up here. Oh crap! I wanted to go back. You got to double tap, close the app, and it'll start.
Okay, so.
Yes. Swipe up, and then restart it.
Are you kidding me?
100%.
That's such a hack. Oh, man.
I got it.
Yes, I'm gonna dominate this now at work. Let's go.
You got it.
Yeah, I did.
I don't know what number we are.
Hell yeah.
Anybody need coffee or donut? I was about to say.
I know. They're like a study for 5 days.
I don't know. He said we're going.
He's an oral surgeon now. Yeah, like I think he got a 29 or 30 high score. You get 30.
Wow.
Because he started.
But what do you mind?
I don't know how he did it.
Especially back in the day, it was harder to get like numbers when I worked there. And like, I feel like what had to become one.
I mean, we're.
Yeah.
Because we were all making donuts.
That's ridiculous.
I don't know. That's an average, like,
The average is like a 19. Yeah. Well, if
We go for
you are just looking at the DAT, the average is 18, and then to get accepted with level 1, at least it's like 18.
Yeah.
So it's.
Oh, we don't know who's going.
I thought we were group 2.
I thought we were through.
Are we group one?
Oh, okay.
Everyone makes a group two. Everyone's group two. We go, I don't care.
Somebody go.
Yeah, let's just get it done. Group two is taking over. Who has the stuff, Zach?
It's on there.
Oh, it's on the computer?
I put it all on there and run it back.
Tyler, good job. Where is it? Oh, Chrome. I just opened.
Yeah, they don't have the, they wouldn't title transfer.
I'm in a master's program at the University of Louisville. Pull myself away.
There's been a couple times where you were like. That's why it was so fun. The what was going on. I got like boogers up there.
Slide that over here. Jewel pays me. I'm like,
Are we starting with the order? You can start with the schedule.
What I just want you to go. I always scan the class.
Oh, that's smart. Okay. Nice.
Do you wanna do?
This one.
I haven't.
Here's what we can do. What we can do. Oh, this is fantastic. If you could transfer the files to a new folder on the desktop.
Yeah, we did, but they show up as numbers.
Mic drop. That's okay. But label the folder the name
Yeah.
of your.
We've done
Yeah,
that.
we
We're
already
just,
I didn't realize that they were gonna show up as numbers. So.
Yeah,
It was my thing earlier.
So you can just rename it like Friday wrap up, you know.
Well, you have them all blackboard.
I do.
Actually labeled correctly.
But it's sometimes, you know, it doesn't upload or it didn't work or.
My part got all these.
I checked it. I almost sent you guys an email at 11:58. I'm sure it has been. And 3 out of the 4 presentations were.
There's still one.
I don't know. I'll check.
I think
Just give everybody else zeros.
whichever one, there's Crohn's, MG, and ALS, and they're still, that's where I got all this from
You
Blackboard.
uploaded 2. How did you upload 2? It shows your.
I created that.
Oh, you created that, right.
we got this. All right.
Alex, you gotta come up.
4 parts, 6 groups.
All right, so
It's like magic.
I don't know, man. Technology has not been my forte in this class.
Who was 2?
Oh, wait. My best time of my life.
Oh, nice. That was good. Good time. So we're gonna go ahead and start off with our schedule.
Okay.
Basically, this is gonna be real quick, but our patient is a 19-year-old female who's presenting with blood in the stool, and we're gonna get a whole patient workup on that. But across the whole week, we're gonna introduce some different documents that we're gonna be previewing to this class for your review, and there will be some questions that we'll then ask the class to sort of address based off of the documents that we're doing. So kind of keep those in mind, and we'll maybe go back to these and talk them over at the very end, see if we can answer 12 of these. So for the beginning, we started out kind of light. Present an overview of Crohn's disease, the symptoms, maybe do something like talk about another inflammatory bowel disease, vitamin D deficiency, ulcerative colitis. And then on Wednesday, we wanted to get a little more detailed and go into like the actual mechanism for the development of Crohn's disease. It's not just the symptoms, but the mechanism for it.
Let me interject here. And feel free if there are any questions. This is kind of a back and forth. It's not just them presenting, you know, kind of like we do in our stuff our week. So why 19-year-old female?
You want me to like answer?
Yeah, because
I didn't want to give it away. Okay, yeah.
Well, if you're going to cover that later, then we can.
Yeah, maybe we should just answer and sort of with the patient. I don't know.
No, that's okay. No, actually, I like this. So, we'll get to the 19-year-old female later, and why you chose that. So, for part 2, it looks like for Mondays, I guess that's for Monday's assignment. So I'm looking through the questions, and I like questions 3 and 4. But when you look at 1 and 2, tell me what the difference is functionally between questions 1 and 2, because for me, it looks like they're kind of the same thing.
One is more clinical presentation. 2 is
Okay.
more anatomy of Crohn's because it can occur from mouth all the way to anus. So you want to like.
So maybe
Specify.
tweak. Oh yeah, and then also as we're going through this, I'll recommend, hey, change this or tweak that before you upload the final ones. Maybe go back and make those changes. So I don't know if somebody wants to be a writer, because this is kind of one way to help. And in fact, this is benefiting you as well, because you'll probably use these as an illustrative case presentation down the road, right? Go ahead.
So are we, like, when you give us advice, do we need to go back and edit
Yes,
it and re-upload it? Okay.
yeah. Edit it and then re-upload it. And it doesn't have to be like crazy. You can just say like change number 1, So Julia, I see what you're saying with the clinical, but you may want to,
I see what you're
Perhaps-
saying, that makes sense. to
well,
me.
I see what you're getting at, so maybe change question 1 or question 2 to have clinical presentation actually in the
Like visual,
question.
yeah.
Right, so if, what does a patient come into the clinic complaining of that has Crohn's disease? And then the second one, you can say like, where is Crohn's disease, or what does it say, where is Crohn's disease?
Yeah, we wanted to go with like why is Gamora?
So maybe, because that one's like, where is it? That's kind of, so you could say,
Too simple.
be more specific, like where in the body does Crohn's disease manifest or present symptoms, or, something like that. So that's just a small thing.
Can
Okay.
I go off that for a second?
Sure.
Does everybody know, or does anybody know IBS versus IBD? Can someone know those acronyms and know the difference?
Irritable bowel syndrome.
Irritable bowel syndrome and inflammatory bowel disease. And so you can kind of tell a syndrome is just a group of symptoms. It's a lot more generalized. A disease is a very specific thing. So when you think about the syndrome, irritable bowel, is that it? Yeah, I think so. Irritable bowel syndrome, that's an umbrella. And then you have Crohn's and ulcerative colitis. So I was thinking maybe perhaps for that, where is the Crohn's, instead it could be, because the difference is that the presentation is exactly the same when they come in the ER, but the difference is the ulcerative colitis can affect a different part of the GI tract more. So we could potentially throw that in there, but we didn't want to stray too far from the
We want to keep things
Crohn's. 'cause-
No, that
Yeah.
makes,
Yeah.
you totally want to make things simple. I think you did a great job of that. I just, as it's written, maybe just make a little bit more distinction between question 1 and question 2. That's all.
Got it.
Continue on.
Yeah, so then as we moved over into Wednesday, we would get a little more complex, so explain the mechanism for Crohn's disease, provide some of the diagnosis criteria for Crohn's disease. So you're gonna need some testing, which we're definitely going to get into as a group, and ways to differentially diagnose this. And then basically, so give an overview of the evaluation for this, so the process, and then how might vitamin D deficiency and Crohn's disease be related. So I would maybe add put a thing just to specify that we're looking for the mechanism there.
Yes, I was actually just, I wasn't
physiological
even gonna
mechanism.
say anything, but I was just thinking about that, is that
Yeah,
really, you don't have to include the word mechanism in every single question. In fact, it might look a little weird, but having a question that is geared towards that, whether it's explaining an issue or, into the mechanism, that's where really the heart is of why I think that this course works out really, really well. Right now. Okay,
absolutely. And then closing things out for Friday, so this one, the nice thing about Friday questions is you can get a little more abstract. And so there are some links between various groups and Crohn's disease, which kind of points, by being able to observe different groups and the commonalities, you might be able to explore different treatments as well. And how is Crohn's disease treated via medication? And also there's some surgical procedures that need to be done, and we need to go into those.
So that right there. So make sure that you say that. What are some of, because it says how is Crohn's disease treated via medication? So that when someone reads that, they just think, oh, like oral medication or maybe injectables or something like that, instead of like surgery. So maybe it could be a little bit more open in terms of how is, or discuss the treatment options for Crohn's disease, including medicine, medication used, surgical procedures, and just make sure you kind of open it up a little bit.
But their part 3 is surgery.
So their part 3, let's see, how is Crohn's disease treated with surgery? You can have 2 questions and 1 question. So if you wanted to kind of open that up or give the student a little bit more direction, you could definitely do that.
We can make those changes. And then the last one will be we're kind of touching on Mondays, but you're going to go in with a lot more physiology, I guess. And so basically talk about the differences between ulcerative colitis and Crohn's disease. Katie has a question.
Are you going to answer question 1? Or can I ask you that now?
We'll talk about it we'll touch on it, but it's
Question 1 for Friday.
Yeah, I'm just curious about the answer. I'm interested.
yeah, we'll touch on it.
Yeah, we got you, girl.
What
Okay.
group is more likely?
So moving on,
Yeah.
we're just gonna get on.
Thank you.
So, real quick, and we won't spend, most times when we go through these presentations, I do tend to focus a little bit more on not just on these, what is this called, the overview or the schedule?
Schedule.
So, it's a challenge, and I definitely acknowledge that, and you all have done a good job of doing it. But it's a challenge to ask questions that are increasing in difficulty, but also relate back to the patient and then really get to the mechanism of the disease. And so Friday's questions really need to be just focused on the crux of the mechanism and maybe even the crux of the treatment. And you have that there. You have like how's it treated via medication or how's it treated via surgery? But and I'd have to think about this to sort of wordsmith it, but something that would bring each question connected back to Crohn's disease in terms of as a whole. I think maybe adding a second part to questions 2 and 3.
Yep.
Might be a little bit more appropriate for a Friday question, which is it's a fastball Friday, so you want the hard balls. For them. Go ahead, Macy.
I was just gonna say, when Julia was talking, I was gonna say it would be a good question to compare and contrast the ulcerative colitis and the Crohn's disease. So I think that's a good question that you guys have.
Yeah. Oh, I agree. I think 4. Yeah, that's a really, really good question. That's a great question. Any other comments or go ahead.
Wait, you could probably answer number 1 with just 2 words. So I don't know if they're like.
No, there's a lot more. There's a lot more to that.
Okay.
I would be very impressed if you could answer it.
So, but I do see what he is saying, because that first part right there, are there many more groups to present with? The fact that you have explained there is
If
really
they have
important.
one word would have to be yes, and then you would have to explain in one
With one
word
word.
why.
Well, no. I we don't want to dissect his comment, but I think getting to the heart of the comment is that, and I kind of read this as well, is that because if you didn't have explained there, that wouldn't be really all that more of an open-ended question. Like 2, 3, and 4 are really great because they're open-ended in terms of asking the question. But so maybe reword 3 or sorry, not 3, 1, 2, or maybe add on to it a little bit. Maybe I mean explain. I think it's okay as it is, but it could be could be great. And this is, I want everybody to hear, this is not me like hammering on group 1 for volume. Like this is a work in progress. Like we're working through this, and your input is valued, their input is valued. And so don't group 1 or 2, whatever group you are, don't hear us saying this and be like, oh, I'm frustrated because they're picking our case study part. No, this is a safe zone, right? We're all here to help.
We're still at 100% for a grade.
Okay, great. All right, continue on. I just want to make sure that we're all happy. And if not, you do it.
Any other
All right.
last comments?
No, I think we're gonna move on.
How do anybody whatever it is?
Yeah, let's keep your whole comments, Alex. Everybody else is welcome. Go ahead and write them down. Think about them for a little bit.
Alex's blood comment. You could answer question 1 and 2.
Yeah, I gotta clap back on a question
Go
like
ahead.
that. Sorry.
Go ahead and cut
Like, let's see that. Let's see it.
Like, I got 2 words for you.
Yeah.
But
Oh, man.
Yes, and then that would be very impressive.
No spaces, you just have to say
Albert.
it.
All right, so this patient, go ahead, choose.
Should I read through it or? do you
Yeah,
want
sure,
to
why
do
not?
it?
That'll be
Okay, all
fun.
right. This will be fun, everybody. Listen up. The patient is a 19-year-old female who presents to the emergency department complaining of an episode of hematochezia. That's how I say it in my head. Hematochezia. Okay. Ketsia? Ooh, that sounds-
Actually, it might be Kezia.
I like
Kezia.
Kezia.
Hematochezia. Okay, hematochezia. Oh yeah, that sounds good. That occurred yesterday at 4 o'clock. She characterizes the quality of the blood in her stool as bright red. The patient also complains of cramping, abdominal pain, chronic intermittent episodes of diarrhea, fatigue, weakness, chronic constipation, and unintentional weight loss. She states that she often feels bloated and hasn't had much of an appetite, but she denies noticing any fever or urinary problems. She also denies the classic complaints of chest pain, shortness of air, vomiting, and all other complaints at this time.
Wait. I'm sorry. Denies? What do you mean denies?
Like the physician said, do you have any chest pain? She said no. A lot of times they ask it just so we can mark it no.
That's the most common phrase.
Yeah. And shortness of air, shortness of breath, but for some reason the doctors I work for say shortness of breath doesn't make sense and they would rather be shortness of air. So that's why.
Is that the phrase? You said that's the phrasing. Sorry, that was the prescribed. Like who's been described?
Patient denied.
They say patient denied. They don't say
confirms,
patient.
patient denies.
Oh, okay, so is that what they do?
Yeah.
No, that's cool.
This is like my area.
Do you have a
Keep going.
Julia's a Alex, you have a question real quick.
It's like all my research and shadowing.
Oh, here we go.
This is the one you wanted. So
Oh yeah, you're right.
Go ahead, Alex.
Would the blood in the stool be a darker red since it's in the colon?
It doesn't. We don't know, and it can present at any. It can present as dark stool. It can present as bright red in the stool. It's an entire spectrum, and that's why you can't determine Crohn's from a clinical presentation.
Absolutely. We're gonna
Subjective.
we can adjust that by the presentation of this bigger
Yeah.
disease.
Basically, the answer is no to that because it's such a wide spectrum that you can't determine anything like that. The patient also notes a history of bone fracture, stating she's broken both her clavicle and her humerus of her left upper extremity within the past year and a half. She denies a history of smoking, hypertension, diabetes, and other GI problems.
Okay.
Okay.
My question, go ahead.
All right, so we are going to dig a little deeper. So the main reason she's here today is the red blood in her stool because that freaked her out. So she decided to come in. Studying for the problem. She's a college student. She just finished class for the day. She walked back to her dorm. And she doesn't feel like she was doing anything in particular because she does this every day, just a normal, unremarkable day. Severity of symptoms. She said it didn't seem like a huge amount, but like any amount would cause concern. And she noticed red like in the commode itself and then pink when she wiped. Associated symptoms. She states that she's lost 15 pounds in the past couple months. And that when she walks up the stairs, she's noticing that she's feeling a lot more fatigued. And she has random cramping in her stomach that doesn't line up with her menstruation. And then prior treatment, she gets physicals for school. And so I guess she may have said something to her pediatrician about having like some GI issues. And so she's been diagnosed as lactose intolerant. So she tries to stay away from milk products. And then preceding illness, like we mentioned up there, she broke her clavicle 10 months ago and then the proximal humerus of her left arm about 16 months ago. And then she has seasonal allergies, which have been bothering her, but
The proximal portion.
yes. Yeah.
I'm like. Trampoline.
that's exactly.
That's why I wasn't allowed to have one. Yes.
Even with the vets.
They're acknowledging, it's.
Do you have anything about using the restroom multiple times?
Chronic diarrhea. Anything else?
Two words.
Chronic diarrhea.
I mean, that might not be multiple times.
Before you put your hand on it? I like this.
No, don't. From here on out.
Yeah.
This is a way that Julia can learn patience and
This is yes. I have an issue. Yeah, I have a
smart ass or anything.
yeah. I definitely have an attitude problem sometimes. So apologies.
You're doing
All
great.
right, continue on, please.
Okay, so habits, lifestyle, and environment. She drinks coffee, but not regularly. She, again, has been told she's lactose intolerant, although she says she will still have some ice cream, which can't blame her. Over-the-counter medication, she takes Zyrtec for her allergies, melatonin to sleep, and she takes ibuprofen for her abdominal cramping, but it doesn't really do much.
Is
And
there any
then-
kind of increase in symptoms or awareness when she has the ice cream, or does that? No, okay.
Not that she noted, which, yeah.
That kind of plays in.
Julia Beekler? No, I have no idea.
Yeah, and that kind of plays into like, so she assumed that she was lactose intolerant. That's something that kind of happens. Like a lot of times, like you might just think, well, yeah, I just had a bunch of diarrhea lately, or it's hard to notice like, oh yeah, you didn't get infected with Crohn's.
Yeah.
So
through, oh yeah, psych, surgical, obstetrical history. Oh yeah, she had 2 teeth pulled when she was 10, but nothing else. So she was x-rayed for those fractures that she had, but she has never had a GI workup or any CTs or MRIs. So there's no charts to pull from to see if these are new symptoms or whatever. So you have to do a full workup. Healthcare professional is currently involved. She has a pediatrician, but she's never seen a GI. And so then we'll go through Alexis will do more of this is what we would have ordered or the type of exams we would have run.
Okay, so wait. I'm saying-
We have a separate
No,
document.
no, I'm just looking at.
Okay.
Yeah, I'm just looking at the ones that you ordered. as a physician. General period, vital signs,
And then there's-
Where's you could, so you got a CBC there?
Yeah. This was more physical,
Right,
like
okay, so
immediate.
that's-
Yeah.
Great, I like that.
You guys think about or come across research any stool sample tests?
We
Yeah.
got fecal.
Boom, shakalaka.
Well, for perhaps calprotectin as a measure of inflammation, rather than just blood presence.
That's what the CT will show.
What did you say?
But you can get a specific stool test to check for calprotectin, which
What
is
is-
kind of a measure of inflammation in the intestines.
I don't know anything about that. I've never heard that before.
Calprotectin, I think it's a, yeah, it's a stool sample.
So the inflammation, would the inflammation show up on a CT?
How would you be able to differentiate it and become normal though?
The CT.
Yeah.
What does CT stand for?
Computer tomography.
So would, like, what does it do? What does it tell you? So are we looking, so like an X-ray? Is it what?
Well, I don't know how the radiologist would read it, but it's going to show obstruction. It's going to show
So it will show.
flow. Yeah.
Yeah.
Yeah. So you can.
Thank you.
Yeah.
So potentially inflammation. It'll,
I mean, potentially, but it's more
So what
so.
I've read,
another way that you could look at this, one thing that, so my son had Hirschsprung's disease. He had it, he doesn't have it anymore. But it's basically where he didn't have innervation all the way down, neuronal innervation all the way down to his rectum. So as the intestines are growing in utero, the nerves grow from the stomach, basically the top of the duodenum, all the way down to the rectum. And Hirschsprung's disease patients, it doesn't grow all the way down. So they don't get the contraction and relaxation of the muscles because it's not normally, it's not innervated. And so what happens is, like, if you have any muscle, especially circular muscle, when it's not being used, it atrophies, and circular muscle atrophying will actually cause constriction. And so it caused a blockage. He when he was 11 years old and have surgery for this, actually right over there at that hospital. Everything's great now. But one thing they did to look at a blockage, because they think, oh, it's a meconium plug, it's something else. If there's inflammation, you could do like a barium enema.
we have that.
Oh, you have that?
Yeah.
Oh,
Yeah.
fantastic. So that's one of the things that can help with, like, visualizing blockages. I don't know how much it would help with inflammation necessarily. You probably have to get a.
The enema wasn't really like.
Yeah, I don't even know if I would order an enema here, because it doesn't look like there's a blockage. In fact, it's the opposite, right?
Yeah.
Although some blockages can, especially for younger individuals, they can present by the people, like the individuals having watery, very, very watery stool. What's happening is there's a blockage and really only fluid can get by. And so that happens with impaction with children as well. So continue on. Sorry.
Yeah. So basically, to wrap that up, since you presented to the ER, you would do a CT to look for an emergent situation such as blockage. You would need to consult general surgery immediately for that.
Why is anxious in red? So I see.
A lot of
I like that you highlighted.
Yeah.
Red, so that's good.
A lot of times, one of the things you want to know would be distress level. So, like, a lot of times, some of the physicians I work for, it's automatically in their macro that the patient is always in mild distress because they're in the emergency room.
Right.
But you kind of want to note that a lot of times they put it in case like she's tachycardic or something. It could explain, like,
Why white coat syndrome?
oh yeah, oh, I've never heard that before.
You've never heard of white coat syndrome? So white coat syndrome is like anybody, even other physicians, when you go as a patient and you go into an office, like the doctor's office, to get a checkup, to get whatever else, when that physician walks in, there is a slight physiological response where you get anxious, your heart rate increases, you get nervous, like that, and they've actually categorized, they call that white coat syndrome. So,
So I guess that's
anxious
just to mark off for that too, kind of.
well, and also to explain, potential abnormalities or slightly elevated vital signs, perhaps. But
but which
So-
she does not have here. Like she's completely normal heart and lungs, but
Right.
yeah. She's in mild I guess I could have said she's in mild distress. Like that would probably be the equivalent.
Did you give a respiratory rate?
No, I just put breath sounds are normal and her effort is normal, so she's not like tachypnic or she's not,
There's no strenuous breathing.
no strenuous breathing. Vital signs completely within normal limits. Eye exam unremarkable. She's got no JVD, full range of motion on the neck. She does have erythema to the gums, just diffusely throughout. So they're just like a little bit angry, as my dentist says to me when I don't floss every time. Like, it's like, oh, they're angry today. I'm like, oh God, like, yeah. Abdominal exam, hyperactive bowel sounds. So more activity than normal when you put your little stethoscope down here, you're hearing more stuff going on. And her abdomen is diffusely tender, but no guarding or rebound. So like when you press on her, she's not like, ah, like it's just like, she's a little sensitive. Yeah. Yeah. And then digital rectal exam, everybody's favorite. You always want to mark on your chart female chaperone if it's a female patient. And then, yes. And then positive digital rectal exam. And that's just where they shove a finger up there and they can just see.
Up where?
That's not up the
Yeah, we actually,
rectum.
So you're gonna be, you gotta say, yeah, so
Exactly.
you
Yeah.
insert a digit, a
Yeah.
lubricated gloved digit, right? In the anus for what? Well, what's the purpose?
So they can, usually you can see hemorrhoids and all that kind of stuff. It's just physically so they can see right away if there's blood right there.
And, right, so you're looking for what? What did you say?
Rectal tone?
So potentially rectal tone, maybe in an elderly individual, but like for a 17-year-old, perhaps not. But no, that's a good thought. But really, what did she come in for? She came in for like blood, bright blood in the stool. And so with a digital rectal exam, what you're going to be able to do, perhaps, is feel for hemorrhoids, be able to see if you see any bulging or if there are any fissures, right? If it's incredibly uncomfortable, like pain, like it shouldn't be super painful with a digital rectal. Yeah, it's going to be uncomfortable. If anybody, sticks a digit up your rectum, it's going to feel uncomfortable, which is why they tell you to lay on your side, to relax, right? So for males, this is one way that they can do a prostate exam, right? And so what you're looking for an anal fissure. You're looking for any just really abnormalities that could be a cause of this bright red blood that she's seeing in her stool.
and thankfully, Alex actually volunteered for us to do a class.
No, we're not. Yeah, we don't pick on Alex. He's a cool cat.
And I chose to put that in the physical exam because that's often done on initial, when the doctor first goes in the room. That's not something you order. And then you would order fecal occult hemocold blood test for the stool sample itself.
For you said digital rectal exam, so female chaperone present simply because our patient is female. So it is standard operating procedure. If it's a male does it. If it's a female does it.
If it's a male, there's no procedure because it can be done by any physician or whatever. But if it's a female
so
patient,
a female doctor doesn't have to have a male
correct.
present. Isn't that
As far as I'm aware, but there's only one female physician at that disease, and I've only worked with her one time.
we don't have to get into it, but it's very curious, especially in this day and age of equality and equal rights and all sort of stuff. For me, hey, if I'm bleeding out of my anus and my rectum, I don't care. I'm scared if it's Joe Schmo who's wearing gloves and don't take any longer time than you need to. I don't care if it's a female doctor either. There's no problem for me, but it's interesting that's not. I wonder if it goes back to potentially when you look at sexual harassment lawsuits and like just statistically from a hospital.
It's probably
it's a lot more, like probably overwhelmingly so female.
Well, it's like you could compare it to Title IX. Like they didn't make Title IX so that men could have.
Right.
Yeah, so it's like this is only really females have really been affected in problems like that.
Yeah, we need to be very clear that part of this arises from men for male doctors or male providers abusing their power. It's not. It is the minority. I
Which
think that's
still,
fair to
yeah,
say.
I would say.
But there are some highly publicized cases of male providers abusing that power.
And it's still a male majority, I would say, in all the hospitals I've worked in the ER. It's still, most physicians are male. Yeah.
Yeah.
I mean,
Yeah.
But I mean, it's a
I've also
female.
gotta
got
take-
female doctors having issues with male patients too. So
Yeah.
it really could be just.
Well,
both
and,
ways.
and that's another, that was kind of the issue, whether it's, a female doctor, doing something inappropriate, but also,
No, I
like
mean,
you said, no, I know,
Oh,
male
okay.
patients
Yeah.
saying something or doing something to make the female doctor uncomfortable, right? So that's kind of what I was kind of getting at. I thought it was just interesting that it's not just to cover all their bases the same way. All right, we've spent a lot of time on that, so continue on.
With that, I'm done
We're
with
done with
this.
the digital rectal exam.
That's
Okay.
it. No, Chris.
Thank you.
Very good part.
Oh, yeah. Thank you, Iman.
It was.
So let's go to, what do you want to do next?
I mean, let's just intro.
Yeah,
Intro
the
something.
intro.
Let's go ahead.
You go over the test results yet or no?
Oh, you want to do that next?
Well, we just went over the
Yeah.
patient information, so I kind of want to do the test results.
Yeah, let's do that.
Just because it's.
I still don't know what this is. really.
Yeah, maybe we should.
Like, I honestly have no idea what
Can
this is.
we introduce the disease?
Okay, hold on, wait. This is the day of democracy. Who wants to go see the intro first? Who wants to see the test results? I am overruled. Go to the intro. All right, so what is Crohn's disease? Go ahead, the introduction.
Okay. Yeah, this picture right here is just kind of to show you, just basically this is what normal, I think, colon looks like, and then this is the inflamed colon with the Crohn's.
Is that colon?
I think that's what the picture says.
The normal one's a transverse colon.
Is that? Are you sure?
Yeah.
And then just a brief explanation of Crohn's, it's inflammation and it can occur anywhere from the mouth to the anus. I've got specific percentages later on in the issues explained, but I think it mainly occurs in the small bowel.
Keep talking. You
Do you want to move it, Kayla, or do you want me to?
Oh,
Oh, awesome.
you.
Okay.
Good.
And just to kind of give a little brief example of what might cause Crohn's, there's not a definitive cause, but maybe a collection of things that they think could lead to Crohn's, such as it being hereditary. It's usually seen as an immune response, like an imbalance between pro-immune and anti-immune systems not working together. And then environmental factors, such as, I know it said, people who smoke or those who live in high polluted areas might be more prone to the inflammation, and all these combined can lead to Crohn's disease. This is a little bit of the mechanism behind it. Like it says, some of the triggering factors might be smoking, environment, stress. All of these can lead to different molecular mechanisms because, like I said, they don't know exactly the cause. So it could be your genome, epigenome, could be an immune response, or microbiome, or a combination of these things.
But is it developmental over time then though?
Yeah, that's where I can
Or
come
is
in and
it-
say, answer the 19-year-old question presentation, age 18 to 30.
Okay.
Mostly. And yeah, you can usually see growth problems or fracture.
Like, does it tend to back off? Or
No.
is it what you have, you have?
1/3 or maybe 2/3 of patients eventually will need some type of surgery to help relieve symptoms. And it doesn't treat the disease. It's just eventually you're going to get some obstruction or something bad's going to happen from it. So
You can cross your fingers. I mean, there is a minority, but about 10 to 50% of patients do, after a major flare-up, they go into a prolonged remission. We'll talk about that. We'll cover that more in the Friday wrap-up. And again, that's a minority. It's substantial, but it's still a minority.
And this picture also just kind of goes to show, based on what your factors might be, plus your genome and what it's presenting like, they can better tailor a treatment to kind of target what they think your specific cause may be. And then the second part of our presentation is going to be on vitamin D deficiency. So this is just kind of a start from Dr. Joshua's notes on how vitamin D is produced, starting with the precursor and then all the way down here with parathyroid hormone stimulating or inhibiting to the active and the inactive form of vitamin D. And this is explained a little bit later, but some of the reasons for decreased vitamin D, just to point some out, like low cholesterol, smoking.
More video games? Indoor.
Oh, this is just showing you.
So, yeah,
a lot
so
of different
there are, yeah, so we have right here the results are so different things that result from decreased vitamin D, and then many causes
You
of
can even see
increased
the
vitamin D. Now
crumbs
remember
right
that
there.
UV is really important for activating that precursor. So if you are spending more time indoors, or if you live in a northerly environment, that is a very real thing. You are decreasing your amount of time to that endogenous production of vitamin D, and so you're going to need to supplement that somehow. Now
Sorry.
So there are enriched foods with vitamin D that you can take, and you would need to actually make sure that you're taking in a proper amount of vitamin D in those situations. If you're avoiding sunlight, if you're on your smartphone a lot.
Is vitamin D more effectively generated and or absorbed in the body through sunlight mechanism or through eating foods? Where's the majority of our, which of those two methods are the,
I'd say.
more effective?
Think about it, like
You synthesize more vitamin D in 15 minutes of sunlight than taking 8 vitamin D pills in one day.
Nice.
By far.
Okay.
That's good to know.
we can think about it like this, like our awareness of vitamin D, and so our examination and enrichment of certain foods, because a lot of them are somehow fortified, either as fortified cheese or dairy product, generally speaking. Yellow things have a lot of vitamin D. So really, and so, but we've only really been aware of vitamins in the last 50 years or so. But yet, obviously, it is there's a substantial endogenous mechanism for it. Yes.
Have you told us the link between vitamin D and Crohn's yet?
We're keeping that as a mystery.
Even though it's a mystery. So
Yeah.
why don't we just intro that? That way we can have a little bit of reference or understanding of why we're talking about vitamin D.
So I don't think we're going to talk about the issues explained.
Oh wait, did you finish this?
Pretty much. I mean, there was just weird. This was talking more about like our little schedule that we were doing.
So perhaps maybe even in a slide in the intro, like if I were to tell you to go back and revamp this, maybe add a slide in the intro that gives us an indication of why we're talking about Crohn's and vitamin D in the same presentation.
Can anybody answer that question? Like,
Yeah.
why would you
That's
think they're related?
That's a fantastic good question.
Yeah.
Somebody other than Austin, because I think Austin knows the answer.
Absorption.
Where?
Yeah, let's throw back to
So what
If
is
you're
vitamin?
gonna have a surgery to prevent it possibly, then you wouldn't want to bother the.
Well,
You never want to bother them.
you never want to bother
Probably not
the
the
bottom is the shortest segment of. But
So,
Okay, well,
So-
we can that's the answer. Yeah, we can get into it now. But yeah, that's the answer. They're connected because it's reabsorption problem and it kind of like feeds off of it. You don't get enough, and then blood
Yes.
cell issues.
So, and also, what kind of a vitamin is vitamin D?
Steroid.
Yeah.
Fat
So
soluble or water
it
soluble?
is
Nice,
lipid
Chelsea.
soluble. All right, we're good.
ADEK.
80 EK, yeah. Do not forget those. Cool. So yeah, we have a massive issues explained that I think we're gonna not necessarily read every single word in there, but
No, not really, but I think it's important to go through this because this is where really the explanation comes. Go ahead.
Well, like I mentioned earlier, like this is kind of how the breakdown of where it can present at, like 45% is seen in the small bowel and the colon, 20% only in the colon, and then 30% in the small bowel, just based on different patients. It's immunologically mediated.
I'm sorry, go back up. Let's see. Onset and reactivation of disease are triggered by environmental effects of transient communication barrier, stimulating in response.
It's not an autoimmune thing, but it's immune related. The body's not attacking itself, but it has issues.
So it seems like it has a large part to play. Well, let me rewind back. So the gut microbia, like the gut microbiome, is a really hot topic of research in the past decade or so. It's been a really large focus in revealing a lot of aspects of how we act, even our moods, are not only influenced by the species of specific species of gut, bacteria that we have, but it's also the levels at which we have them. And where do we get our gut bacteria from? Where do we get that from?
The appendix. Can I open that?
The appendix
door?
The appendix is it's actually a great. You're right. We don't get it from the appendix. When we're babies, where do we get our gut
Mother.
microbiome? We get it from the mother. Right? We get it from the mother.
Which is, you were touching on that last week, I believe it was, but that is a huge reason why they're investigating cesarean sections much further as far as like the long-term effects of them. In fact, one of the most commonly things done in delivery is not even with a cesarean section, is to go ahead and swab the mother's vagina and then, or swab the area. Yeah. I'm going to do the best.
Go ahead and say it. Yeah, you got it.
Yeah. So and then they go ahead and
take bacteria from the mother.
Take the bacteria after that, and then they go ahead and swab it over the baby.
Right. You're 100% right on that, and there's actually a lot of correlative studies that they found with vaginal versus cesarean section births in terms of incidence of development of asthma, looking at allergies, looking at a lot of different things. Like, there's even a lot of stuff that goes on with just as the baby is forced and compressed through the birth canal, the vaginal tract, right? It's compressed. So a lot of that, almost all of that fluid gets out of the baby really, really quickly. And that also is a driving force for the baby taking the first breath. Is that, there's a lot of stuff going on there. Bacteria inoculation included, right? So there's a ton of new research that we didn't even think about. And then what's really scary is that in the United States and in Kentucky, upwards of 40% of births are cesarean section. That is ridiculous, because the World Health Organization has said that in a normal country, in a normal first world country with modern medicine, the cesarean section rate should be below 5%. And we have in Kentucky upwards of a cesarean section rate of 40%. It's staggering. So anyway, continue on.
Yeah, and closing that out, it's important to remember that you are a walking microbiome. You have more bacterial cells in your body than you have actual eukaryotic cells.
Do they know how many cells you have in your body? About how many cells? If you ask Siri, it's estimated, actually not ask Siri, actually it's a PubMed article, it's estimated anywhere between 30 and 40 trillion cells in our body. And studies have shown that there's upwards of 100 trillion to maybe even 10 times, so up to 300 trillion bacterial cells in your body. Right? So that's a good point. You actually are more not you than you. Pretty cool.
Yeah, the size of the cells are very.
Whoa, I just blew your mind. That was so
Philosophy
deep,
and
right?
physiology,
So
Dr.
deep.
B.
I'm going to start up. That's going to be my new podcast, right? Go ahead. Continue on.
Yeah, I mean, it's a group presentation.
Yeah, we're coming
I don't care.
You want to take over a little bit, Alexis, or
you feel most comfortable.
whatever you feel like.
Okay. The symptoms that are usually related to Crohn's include rectal bleeding, which we saw in our patient, fever, weight loss, anorexia, which she also had some unexplained weight loss over the last few months, nausea, vomiting, malnutrition, vitamin deficiencies, generalized, is that a word?
That was an audible asterisk. That was.
Some generalized fatigue, bone loss, and psychosocial issues.
Absolutely, Avi.
When you're talking about anorexia as a symptom,
Yeah, see, I don't like that they use it either. It actually just means unexplained weight loss. But when we think about it, yeah, we think about it as
There is-
psychological illness.
Purposeful.
So-
And it's, in the DSM, it's classified as anorexia nervosa. So I'm thinking that the nervosa implies the psych. That's my own interpretation.
So
I don't
when we
know.
say
Yeah, it's-
anorexia, it's just weight loss.
Right, and then if you have
Without an
nervosa,
explanation.
I guess that means some sort of like, yeah, you
Mental
have like an
against it.
anxiety induced or whatever you wanna call it. Yeah,
And
so I think that's. the
That's
difference.
going to play into something that we're going to touch several more times throughout this is, again, you need to remember that this is a multifaceted disease that you're experiencing. And so there are going to be a lot of social and psychological things that are going to come with it. If you are having major issues with your gut constantly, and
Especially as a teen.
as a teenager, like that is going to affect you, and then that's going to perpetuate this. Your gut is directly influenced by your relaxation or your stress.
And then bathroom
So actually,
usage in schools.
I have a friend who has Crohn's disease, and another symptom that you might see is one that he has. He has sort of what we're called flare-ups. So Crohn's disease is it's not like you have all these symptoms chronically until you're treated and then they're gone. It's what he says are called flare-ups, and you just treat the flare-ups, and usually once those kind of go away. But one of the other symptoms he has is rosacea. So it's sort of like, it's not acne, but it's like irritation and reddening, especially of the cheeks and the forehead area, where it looks sort of like angry red and not scaly, but almost it's not acne.
Flaky.
Yeah, but dry, and that's another symptom that like you said, with the immune system, maybe also in the gut, but it can present itself as. Okay, continue on.
So for some of the diagnosis criteria, you could possibly see, like we said earlier, a presence of tachycardia. If you're really anxious all the time, in terms, well, not all the time, but if you're having a flare up, it could cause tachycardia. Intermittent fever, the presence of possibly fistulas or some arthritis.
As far as that
Sorry.
as far as that dermatology, like some of these pictures are pretty, like, we didn't do our patient have any derm issues just because like that pyoderma gangrenosum is pretty foul to look at.
You
So
can Google it.
Gangrene, right?
yeah, there's some pretty nasty pictures. But yeah, that's actually fairly common with it.
Is that right? It's common.
Not common, but it's
There is an
actually, yeah, I would
incidence of
say,
like-
yeah.
Where?
Like, does the majority get it? No, but
Derm symptoms are common. I wouldn't say.
Where's gangrene common? Like where location wise?
Oh, I've seen it. Well, if it like
extremities or could it be random?
extremities.
Or is it?
legs, arms.
Why?
I don't know.
Why do you think?
I don't know.
No, that I would. So I'm gonna hypothesize here. But
Sure,
if
yeah.
you are malnourished, then there's a chance of tissue death. There's also
Right, so that potentially is a connection.
Yeah, there's
If
also,
you're malnourished because you're anxious, because you're throwing up, you also have rampant diarrhea, you're probably dehydrated, and like you said, you're not getting enough nutrients. Then that would most likely, primarily, first, present itself in the most distal portions of your body where that are used to having potentially restricted blood flow, and being okay. But
I would say to continue off that, since she's presenting with hematopesia, a lot of times you can have blood loss induced symptoms, and I would say the vascular issue of not perfusing your skin could potentially go along with that.
how are her lab results in terms of her glucose, in terms of her? I mean, like,
Glucose was fine.
Glucose is good,
She's
yeah.
definitely anemic, which
Yeah.
even for routine laboratories, we have that. That's what the complete blood cell count counts for.
which could even more so be attributable to, or at least linked to any of, ischemia to distal tissues. You don't have enough iron, you're not going to have enough red blood cells. You don't have red blood cells, you're not going to be able to transport tissue to the body. So that kind of goes back to the respiratory. I'm curious to see if she had elevated respiratory rate. And I know you guys didn't add that in there, that's fine.
Yeah.
But that would have been a cool symptom to look at.
Yeah, and then even one more thing, just really driving home that this is a multifaceted disease. Part of what exacerbates, or one of the causes, but also exacerbants of this Crohn's disease is unregulated apoptosis. In which case, if you're looking at the GI tract, that is all epithelial tissue, and then if you're seeing gangrene in the extremities, that is also similar tissue. So if you have massive migration, or I should say, or effort from the immune system that is being ramped up, there's every reason to believe that you could have inflammation and potential, infections that occur in the extremities where there's lower perfusion already.
So what you're saying there is that the rapidly dividing tissues are somewhat more susceptible to immune response with Crohn's disease?
So the Crohn's disease, there's a reason that you're seeing it in the rapidly dividing tissue. So it's that inflammation and the proliferation of cells there. There's just such a greater opportunity for for some kind of a mechanism to get a little messed up or.
So do you see any type of hair loss or hair issues with these patients?
Maybe if you had some blood loss-induced vitamin B or B12 or folic acid deficiency or something.
Well, I just asked like the hair follicle. When you think of rapidly divided tissues, right? You think of the GI tract, you think of the skin, and then I also think of hair, right? Basically, they're areas that chemotherapeutic drugs target.
Right.
So if it's rapidly divided tissues as a whole, I would think perhaps that you would see either, not necessarily maybe hair loss, but maybe a lack of hair growth or a slow. So I'm just asking out of curiosity, did you in your research come across any type of symptom that linked hair?
No, and I would respond by saying I think that one of the keys about Crohn's is the enterobacteria. I think that's one of the big.
So that is actually what I was glad you said that. I gave you $5 for queuing that up. So I think that is a key component. So yes, I do think that the rapidly dividing tissue of the GI tract does perhaps allow a more fertile, if you will, environment for for inflammation to occur. But the other really important key component is, where do we have the most bacteria in our bodies? It's in the GI tract and on our skin, which is, when we look at symptoms, those are two main places that are going to be affected. And you throw in a vitamin deficiency that's linked to it anyway, then you're going to screw with all the levels of all the different bacteria, and maybe not change bacteria, but remember that like the bacterial colonies, we're living in symbiosis, but if you think about it as like a billion tiny little armies in our GI tract that have a hierarchy. Right? So there are different levels, and if Army A is always on top and it beats down all the other armies, or it keeps them, you screw with Army A's strength by having a vitamin deficiency. Now the Army A goes down, and then that gives B an ability to rise up, which is the immune system will look at that. They're like, hey, something foreign, let's kill it with fire, flare up, boom.
You can also say that the bacteria are very opportunistic in regarding, rather than just each other, our body. Like they see a slit in our body, they're going to take full advantage of a glucose-filled bloodstream.
Yeah. Exactly, and I should not open the door, but like that's a big part of you'll see the treatments can also exacerbate the actual
methotrexate was actually one of the.
So we're definitely going to talk about that.
All right, keep going.
We'll get to that in the next hour.
Labs.
Did you ever? I'm sorry. You said appendix? What were you saying about?
Oh yeah. So one of the doctors I was working with the other day, because we just take those out. Like appendix doesn't do anything, useless organ.
Did we talk about this before a couple weeks ago?
I don't know. Maybe
I talked to somebody.
Wait, maybe did you tell me this?
Yeah.
Okay, never mind then. It wasn't one of my
No, but I want you to say.
Okay, well it was they think potentially, because he said there's a big new field of gut, bacteria. That's like a cool science now. But perhaps when you wipe out you take a bunch of antibiotics and you wipe out all the bacteria in your gut system. The appendix holds the fingerprint. Everybody's is completely unique. Your ratios of gut bacteria, so they think that the appendix houses like a little sample of your gut biome. And so when that happens, the appendix is able to be the initiator of reestablishing the bacteria.
Reseeding. Yeah, actually,
Reseeding.
I was the one. Yeah.
Did you tell me that?
Yeah.
Okay, all
Yeah.
right.
So what happens is that it's and you say flushing out a bunch of antibiotics, but back in the day, right, we thought the appendix was a vestigial organ, right? We thought that it didn't really have a function. They take it out, no problem. But what they're finding out is that when less antibiotics, because they're only invention of the past 150 years, I think you live next door, is that when we would drink contaminated water or dysentery was really, really common. And so as we would go through these bouts of normal rampant diarrhea, it would act as a reservoir of native bacteria in order to reseed.
The appendix is awful.
Reseed. The appendix is right off of what's called the cecal sac. So if you've got your small intestine comes over here, right, you go to craziness, and then you've got your ileocecal valve, ileum and the cecum right here, and then the cecum it actually kind of goes down here, and then the appendix is off the cecum, but stool really doesn't come down far here. It actually gets pushed up here to the ascending, transverse, descending, sigmoid colon to the rectum, and then out the body when we defecate. But it's really neat because it's not it's off the beaten path of the normal route for stool and feces. Well, I guess time to go and turn into stool and feces. Okay, continue on. This is exciting. I like this stuff.
Yeah, it's
So, Austin, do you have a question?
Yes, yeah, just kind of relating to the whole bacteria thing before we get off that. Did you guys come across anything related to fecal matter transplants?
Ooh,
That's how I love
Great
that
question.
topic.
We can
Eat
definitely
food to help yourself.
give a. Actually, this was in the news recently as well. Give like a 1 minute answer to that question.
You reestablish your gut bacteria by eating healthy people's poop.
Not necessarily, no. But
Or you insert it rectally, that's what they told me.
You can do it. Have you guys seen dogs ever in farm dogs especially like eat feces? And you're like, no, don't do that. A lot of times they'll eat grass and feces in order to reestablish that normal gut microbiota. You gotta be careful. In the news, there was, I think it was on CNN or Fox News, there was a person who did, it's not FDA approved, but they went abroad and did it. And they actually got transfused with someone who had multiple resistance. Was it Staphylococcus?
Oh,
I don't know what it is,
MRSA?
but they got basically it was antibiotic resistant gut bacteria. They died.
Oh my god.
So
So
they
you
had
have
to-
not
So it's not, I don't think it's approved yet.
it's not as the United States.
But it is approved for C.
of six to
Well,
see treatment.
it's
C. diff. I see. I didn't know it was approved in the United States for C. diff.
it is definitely indicated in C.
Well,
And you insert it,
I didn't know
that's
it was
right, yeah, you
approved.
insert it rectally for C. That's what they were, you like, yeah, it doesn't go down your.
Well,
Right.
I think the trials for Crohn's, I think
you can take it.
gelatin.
That can withstand that stomach acid and even the small intestine, and then they get reseeded.
Mhm.
There was a guy who did this back like 10, not 10, maybe like 4 years ago. Anyway, go ahead.
Yeah.
You can look it up later. All right, so this is the.
So yeah, we jumped forward to our test results because we're gonna hit it again in the Friday wrap up as well, and so we'll be here till noon or well past.
Go ahead, Alexis.
So as we had all hit on before, there's like a huge umbrella of inflammatory bowel diseases. So you basically want to do a series of tests just to confirm that there's like inflammation or some kind of obstruction, and then to differentiate or rule out what exactly it could be or it wouldn't be. So, sorry. That'll include a complete blood cell count test, a serum blood level test, the fecal occult blood test, and a CT or MRI is what I saw.
What are bands?
We had this whole conversation and took it out of ours because bands are T and B cells that aren't yet developed. So they're kind of like precursor cells is what they are. So in terms of when you do a count of those, like if you see those are high, you could have an infection that the immune system has sensed, but it's just coming into its stages where it can fight back against them. But commonly also when you do complete blood counts, there's a lot of them that also won't include bands, and that means they are just sequestered in with the TME cells, like it's all part of that percentage.
But importantly, to touch on that, what is that like? So yeah, what are the two, or what's the main tissue that proliferates? If you're having, especially if you're having some kind of an immune issue, you're going to have a rapid proliferation. Yeah, and your immune system is going to be ramped up because it's trying to fight what your body is reacting to as an infection or some kind of a stimulus to. And so if you're seeing the bands, why that is significant as opposed to just lymphocyte count is you're looking a lot of times if it's rapidly proliferating, you're not going to see the mature cells, and sometimes you won't even see the fully mature cells.
It's not like if you're fighting a war, you don't have enough people, you throw out half-trained people as well.
Yep,
Right?
even
So
kids.
those that have no problem kids.
But if it gets real ugly,
If it gets real ugly, right? No.
Yeah.
So that great answer. And then you guys have heard of never let monkeys eat bananas, right?
Yeah.
Yep.
No.
Never
Yes.
let monkeys eat bananas.
Hematopoiesis.
The neutrophils never, lymphocytes let, monkeys, monocytes eat eosinophils, which is opposite. If I see
I was
monkey,
about to say,
would
why
do-
are they associated with bananas?
Yeah, there's nothing in it. It just shows you the prevalence of white blood cells. So never let monkeys eat bananas. Neutrophils, the most prevalent.
So yeah, and again, that's
bananas.
so the monkey would be above the eosinophil.
Yes, exactly.
Yes.
All right, continue on.
Thank you. Moving on.
So,
Or you want to?
Oh yeah, I meant to add the hemoglobin in, Alexis, because I was looking at that and her hemoglobin should probably be 10. That's what we were gonna put in there, because she's a little anemic, she's had some blood loss.
MCV, what is that?
I can't think of it off the top of my head, but
AC might be able to help you out.
Yeah,
there you go.
Mean corpuscular volume.
What is
There we
corpuscular volume?
It is the mean value.
What is it if your mama asks you?
It helps determine the
It's
size
average
of your red blood cells.
Right, so why is it called mean red blood cell volume?
That would be helpful, you know.
Red blood cells used to be called corpuscles, and a cell can be referred to as a corpuscle as well, or used to be, right? And so the MCV, the mean corpuscular volume, refers to the volume of a red blood cell. Now, what would that like? Why are they looking at that?
Well, so this could be two-pronged, because she could have the anemia from the blood loss, and then she could also have the vitamin deficiency, which would lead to, think back to Dr. Ellis, the enlarged red blood cell leading to that macro.
Well, wouldn't anemia cause a high MCV? Because you're getting these red blood cells that are not fully formed, and which they're reticulocytes. Really, reticulocytes, don't they have a larger MCV than?
I just feel like if you have I guess it depends on the etiology.
It could be indicative of a an osmotic issue, whether she's tonicity, but doesn't seem like that's the case. Did you guys just pick low, or did you see low in other?
No,
cases?
yeah, I saw low.
You saw. I'd be curious to see because I've
Yeah, that's a pretty characteristic one, actually. We'll have to look at it.
Yeah.
Yeah,
that was
I see that.
almost across the board. Yeah, anemia, low hemoglobin, low MCV, kind of. But we'll look into it further just before we.
Go ahead. Also, you have a comment.
Was the question about why the?
Yeah, I was wondering why it was low because it was my understanding that when you have a higher reticulocyte count, those reticulocytes are immature red blood cells, and those red that's
Well, if
why.
she had diarrhea, she's giving off a lot of liquid, so she's going to have a higher protein content. Therefore, it's going to draw volume out of
Let's
the
say
cells.
it's a volume measurement, so it seems like the volume would go down regardless.
Yeah, volume. Because if
because-
you're looking at singular volume, that volume could go way down because with all the diarrhea and stuff that she's been having.
Yeah, potentially. Yeah, maybe I don't know.
So what do I need to change for this?
I mean, it does.
I don't think you need to
Oh, okay.
change. I just want you all to know what
Oh, okay.
MCV is and why it's important.
Oh, you said hemoglobin. You're gonna.
Yeah, I'll add it.
Yeah,
Yeah.
that was a
Go ahead.
So this was her blood chemistry test, just to show that her albumin levels were low. By the way, I took normal values from an adolescent female, so
Okay.
she's 19. Her blood calcium levels were low, indicating that there's some kind of deficiency, and also her vitamin D levels were low.
Yeah.
You have low vitamin D. What are you going to be low on, most likely, systemically?
Calcium.
So
Very
as we had mentioned before, I saw that sometimes you'll do a contrast enema, which can also show this string sign, which is just an indication of inflammation or restriction. This is in the terminal ileum is what they were framing it as. So she was having right lower quadrant pain, I believe.
Is that an ulcer? Like that's an actual
There are
tear into the abdominal
ulcerations.
cavity?
Yes. So I kind of
Interesting.
highlighted the.
Where'd you get that picture?
Is it that website?
Yeah.
Yeah, I signed up for like a free website that has all this awesome stuff. It's like emedicine.medscape
Is that in your
or something.
sites?
Yeah.
Yeah.
Source?
I put
Yeah, but you gotta have my username, so you're not gonna be able to look at it. But
Thanks.
yeah, sorry about that. But it's free, so
Yeah, but Dr. Brainerd will set up a subscription to the process.
yeah.
That's interesting. It's really cool. All right, continue on. I guess that's a lateral view of the. Oh no, that's pelvis. So that's a just mindful.
Right. So here's the CT scan.
What are we looking at here?
Yeah, I'm not doing
The
radiology.
small bowel. I am not either.
Yeah, it's not for me.
It never indicated what exactly was what. It just said small bowel and that there was inflammation in her terminal ileum.
I was gonna say, isn't like the white, like the contrast that the person drinks?
Yeah.
So wait, is this an enema? What are we doing?
And then
No,
it's
this is
up the
This
rectum.
is a CT. Is this contrast?
I believe so. I believe that's what this white.
Well, the white. So you can have a non-contrast where it just still looks at the like an MRI thing is looking at soft tissue. And it looks at the density. All right, continue down. Go ahead, Zach. And Julia.
This is just the pelvic view.
So yeah, no. So this is the CT right here. But
This is also.
Go back up to
Yeah,
the bottom.
Right lower quadrant pain is a common clinical finding.
does everyone know how a CT works, or should I?
Quickly, yes.
All right. So in about 15 minutes, I'm gonna explain.
About 15 seconds.
It's a little bit slow.
There's the website.
All right. So yeah.
There.
So basically, what a CT is, you're taking many slices, and it's basically the way I had it explained to me by an anatomist is you need to think of it as an upskirt view. So basically, if you're looking at this, the person would be laying down and their head would be furthest away from you on their back, and their feet would be closest to you. And so you're taking all these essentially slice or transverse images. And what's really nice as far as imaging with a CT is concerned is you can scroll your way through them. And that's the real benefit to physicians. And so this is one transverse slice, but the physician would be looking at the next one, which is taken, literally just a tenth of a centimeter up, and then the next one, which is another tenth of a centimeter up. And obviously you can be more, you can
The
decide.
less the difference between the change.
Yeah, and you can decide how often you want it to take one of those, and it's going to be it'll be a more expensive procedure. But yeah, it allows you to work your way up from pelvis all the way up through the thorax, even if you wanted to, which not for this patient.
That's why it's most commonly used with the heads, because you can see the different structure.
Absolutely. So it's a great way to get a three-dimensional idea of any kind of trauma or injury by just looking at it, working your way up, literally or millimeter by millimeter.
Okay, all right, continue on.
I did just want to indicate too that location also has a huge indicator of Crohn's disease.
Sorry,
So
it's
it's typically
my house. Sorry.
it's typically seen within the ileum or terminal ileum.
What's string sign?
It indicated that there was some restriction or stricture, I don't know, narrowing within her ileum.
Okay.
All right.
So again, just to reiterate the results, she came in with a stable heart rate and blood pressure. Her fecal occult test was positive, so there was the presence of blood in her stool. Just some of the treatment options that were discussed. So typically with someone who has mild to moderate Crohn's disease, those are the people who haven't come in to be diagnosed yet they have not even yet been diagnosed with Crohn's disease. So you would typically want to start them on obviously the most minimally invasive, which would include drug therapies. So a lot of research articles that I saw recommended a combination therapy.
The combination therapy.
Yes.
So what was that TNF alpha?
The TNF alpha would help to kind of control the immune response, I believe, to the inflammation. But with that, you also have to replenish, I believe, the proliferating cells. And so,
Just for brevity's sake, because we do need to hurry up. So give just one person give like a 2-minute fly through the Friday wrap up, and then I'll look at that later. And we do need to let the other team first out before the.
All right, everybody. This is where it gets really fun. So everything else is just an intro, but anyway. So Crohn's disease, it is a multifaceted disease. There are many, many different things that influence Crohn's disease, and it's environmental factors, heredity, and also the immune system, and it all comes together to make this nasty and awful thing that we have to deal with. We can contrast this to, is one of the two main types of irritable bowel disease, the other one being ulcerative colitis. However, the inflammation is across the whole tissue, whereas ulcerative colitis is just the mucosal layer, and it is located only in the large intestine, usually working your way approximately from the anus and working your way backwards, and it does not affect, and it should not affect any other areas. Now, you might see some systemic issues. And you can read my annotations later, all right? So we went through our patient. We kind of, I hope everybody starts as, kind of figured out our patient and why we were seeing some of the different symptoms that were affecting her. We hit that one to death. There are many different things that are playing into this, and importantly, I just want to talk about the expression of the genes and the genome and how they're playing back on each other. So the microbiome will influence the expression of genes. The immune response will also influence both the microbiome, and it will also go back and influence the gene expression. As a result of that, and this is really like the meat and potatoes of our entire presentation, you can see that there are just a vast multitude of things that are influenced with immune response. The gut microbiome is influencing the immune response, and so you get all these different factors that are either recruiting more macrophages, or we found that the CD4, which is the helper T cells, those are basically the Don Corleone of your immune system. Those are going to be secreting more in it. One of the major factors is tumor necrosis factor alpha, and that is mainly secreted by the macrophages, which are the huge players as far as inflammation is concerned in the epithelial tissue or inflammation systemically. And so, the treatments, which I think you can read through this, but so you're going to basically be trying to target those mechanisms and lower the expression of certain things that either exacerbate it or that are being exacerbated by the Crohn's disease. So you can both work the symptoms and some of the triggers for it. And we can kind of get into that right here. So aminosalicylic acid, everyone should remember that as like aspirin or a derivative of that drug. So those are going to target inflammation. If you hit corticosteroids, then you're looking at more the immune system, so inflammation again. Then immunosuppressants, and this is where it gets really interesting, you're going to be suppressing the actual immune system's expression. So that's something like methotrexate, which we learned about, which will decrease the proliferation of cells, and one of the most proliferative cells, if not the most proliferative cell, would be your immune cells. But you're going to have some major side effects that you're going to experience with that. Furthermore, monoclonal antibodies, which are just extremely hot topic, you're going to be your ability to actually have to put antibodies into the system that will then target the tumor necrosis factors or some of those other cytokines, which then recruit your own immune cells to then go and put those out of the system, which would then, if you do not have those factors in the system, you would then hopefully decrease the recruitment of targeted immune response towards areas of tissue that really didn't need an immune response, you could say. And again, if all this doesn't work, and so a targeted, like the compounded therapy, I think is what we call it, you would try to give some kind of an immunosuppressant and a monoclonal antibody to work with this. And sometimes that doesn't work, and so you're going to actually have part of the organ get damaged, in which case you might need to resect part of that organ. You might need to do some kind of procedure if you have a stricture, so a narrowing, to go ahead and actually restore that. Again, this is one of those perfusion issues, and if you have hypoxia, you're going to have a tissue death. And I really wanted to talk about apoptosis, but we're not going to have time for that. So, all right. Good job.
Next trivia, 10 minutes. Easy, we'll go over. It's okay. We have donuts. Thank you. Good job. I'm just trying to make you rush through it.
Thank you.
Yeah, it really is. Very, very interesting.
We could have given 2 weeks.
All right. So what disease does this next group have?
Let's start us off.
Yeah.
We'll give you an idea of the patient, then we'll give you the introduction.
All right, guys. Also, just a note.
And then we'll hop into the week schedule last.
Just a note, guys. I don't want you to feel like you have to rush through this. I know we're behind the time, but that's just kind of how the cookie crumbles, especially this finals week. So don't feel like you have to rush. Obviously we're not going to be here till 1 o'clock. If we go to 11:30, 11:45, if somebody has to leave, then get up and go. If they've got a previous obligation, that's fine. But I don't want you all to feel like you have to rush this because you worked hard on this and you worked a lot. So also for the people in the audience, grab donuts, grab coffee, use the restroom if you need to, and if you have to step out, just step out for whatever reason. But let's go. Go ahead.
All right, so I'll kick us off with the general findings.
Wait, what
So we're talking about. Yeah. Okay, gotcha. So patient is a 35-year-old woman who first presented 6 months ago for self-diagnosed pregnancy issues. She thinks that she's becoming more tired, much more quickly than she normally would, and that she was drained of energy after a very small task. At the symptoms, it seemed to be correlated with her third trimester of pregnancy, so she seemed to kind of misdiagnose herself in that regard. She had no ptosis, meaning that she had no drooping of the eyelids, so it wasn't, at least at that time, a big indicator. Let's see.
So I'm sorry, but what case study do you have?
So myasthenia gravis.
So the whole point of the way we've done this course, and that's what I'm asking, is that it's not like the typical case study where you make the patient figure out. Like the goal isn't figuring out what they have. The goal is for the mechanism. So it's important just and that you all are kind of on the same page going into it, so we can connect the dots and think about the mechanism. So myasthenia gravis. Okay, go ahead.
All right, so we're right here now. All right. So at the time, the patient was irritable and refused to comply with or allow for any further testing. It was determined that the baby's health was not at risk, and thus she was allowed to return to her normal life.
I'm sorry, let me interject here. I'm sorry. Can we do the intro first so that we, as we're going through the general findings, we'll be able to connect the dots because we'll have at least a framework of the disease, the mechanism, and everything else. And then that way it'll
Sure.
I think perhaps flow better. Go ahead.
Okay. So our presentation is on myasthenia gravis, which is abbreviated MG. It's a chronic autoimmune neuromuscular disease that shows up as muscle weakness. Its prevalence is that 20 out of 100,000 people have this disease. And again, for muscle weakness, it's weakness that fluctuates. So sometimes you see it, sometimes you don't. But there are times where when you do see it, it gets worse, especially in terms of exertion. Like if you're exercising or just even like walking around, moving around. For somebody that for us, when we exercise, we might get a little tired afterwards. People with this disease, they struggle to even just move.
Does it chronically get worse and worse and worse to call death, like some other neuromuscular diseases?
Not usually, because the severity of myasthenia gravis is completely different in patients. If you see a death of myasthenia gravis, it's usually from what we call myasthenia gravis crisis, which is respiratory.
So like a flare-up.
With kind of.
Okay, all right, continue on.
as a hallmark of myasthenia gravis, like we stated, muscle weakness worsens over periods of time and activity and rest. And there are some other hallmarks, such as like the Mary Walker effect. And Mary Walker, she was a physician who found out by using injections of stigmine that you can temporarily fix the weakness of muscles, of that muscular weakness. And we also have ptosis, which is like drooping of the eyelid. It can also be with both eyelids. General mechanism of action. So what generally happens, and we'll go into more detail, is that the acetylcholine receptor, the rate of it is of degradation increases, and this is due to cross-linking of receptors, because what happens is that you have the acetylcholine receptors are targeted by antibodies and when those antibodies, when more and more antibodies attack the acetylcholine receptor, that will lead to cross-linking, which will eventually lead to internalization of those receptors into the cell so that they're not expressed.
What do you mean cross?
We're gonna dig into that
Yeah.
issue
So-
by document some more.
Well, that's okay. Yep. Just go ahead and answer it now. What do you mean by cross-linking of receptors? You don't have to switch over to the document. What do you mean by that?
So from my understanding, cross-linking is like the same as clustering.
Okay.
So when we have antibodies and they're binding to a cell, the antigen binding site are those two ends of the Y, as we learned through our biochem course. And the tail end of it is supposed to bind onto some kind of T cell or some kind of leukocyte within our body that's fight against an infection. When you have certain types of antibodies, they can actually bind to each other as well. So where you might see them binding at those or acetylcholine receptors, the tail ends or the sides of those antibodies can sequence together as well, and it creates this sectioning off where it's pulling all those to a particular area. And that's what we mean by cross-linking.
Gotcha. And that would further inhibit the ability of acetylcholine to, number one, bind those receptors, but also potentially inhibit the receptor recycling sort of
And
pathway.
The cell response is to immediately try and intake those receptors and pull them back in for recycling. So those are no longer expressed effectively.
I wonder if the cross-linking receptors actually, the body can respond by sending more antibodies to, it almost looks like the cross-linking mesh as some foreign antibody, further clumping, because I mean, that's what antibodies do, right? Glutamation is one of their primary ways. Interesting, okay. Go ahead.
So there are two general ways, and like we kind of stated, there's antibodies binding to the acetylcholine receptor active site. These are antibodies coming from the B cells that return within the bone marrow. And what this happens is by binding to the active site of the acetylcholine receptor, you are directly blocking acetylcholine from binding to those receptors. And then another way is that there's an increased number of antibodies binding to the non-binding sites of the acetylcholine receptor. So what this is like, these are just other sites on the receptor that, like, when you have increased binding, so there as more antibodies bind on those non-active sites, you're gonna have it's gonna signal the T cells to come in, and then other immune cells to come and cluster and attack that cell with the acetylcholine receptor.
So can you categorize that as competitive and non-competitive? Or is that just
I wouldn't say non-competitive
Is it non-competitive?
because it's not an allosteric site. These are just
When we say competitive versus non-competitive, we're usually referring to it regulating the function. In this instance, competitive, you could consider if you have an acetylcholine receptor antibody that binds to the active site, you could say that is competitive. But in regarding to non-competitive, there's no guarantee that it's going to inhibit the acetylcholine binding.
It just functions to have T cells.
Yeah. And as an overview, so what again myasthenia gravis is, it deals with the immune system targeting the acetylcholine receptors, leading to muscle weakness. There's several types of immunotherapy with immunosuppressive agents like with stigmine that help to inhibit this, and it can be further divided into 4 different subtypes: focal, generalized, fulminating, and paraneoplastic. So focals where only one body part is involved, and it's usually in the upper portion of the body with the esophagus, and generalized usually all skeletal muscle involved. And fulminating is it's rapidly progressive and gets worse over time. And paraneoplastic is thymoma is present, and what thymoma is, it's like a tumor that is dealing with enlarged. It comes from the epithelial cells from the thymus. So as the thymus becomes more overactive in producing T cells and immune cells, that it becomes enlarged, and that increases the risk for.
And paraneoplastic is a tumor of the thymus. Like that is the specific, that's when you would call it paraneoplastic.
Yep.
Go for it.
Are people born with this, or do they like progressively develop symptoms throughout their life?
That is going to be very well addressed later in our document because of the patient.
Well,
particular.
go ahead and answer
In
the
short,
question now.
in short, they're not born with it because it generally develops over time as an autoimmune disorder. But there are cases that can happen in infants that mimic this disease very closely, but it's not endogenous.
It's not
myasthenia
true
gravis.
myasthenia gravis.
So it is, but it is characterized as an auto.
Absolutely.
Is it inherited?
Not
Well,
really.
you can have genetic predispositions, but
A lot of autoimmune diseases can all be considered inheritable because it is a tendency for your genes to allow for a mutation to happen, or has a coding that if a slight mutation occurred, it would generate the autoimmune disease. So there's not a direct genetic link that has ever been stated with myasthenia gravis, but if you have a family of people that has autoimmune disorders, it's very likely for that family to have children that would suffer
So
from
you
that.
saw it. You saw family. You saw potentially when you were doing all the research on this. Did you see families that tended to have more individuals with MG, and or like did it run somewhat in families? Is the predisposition that high enough where, or is it just very sporadic and random, and one family member's affected and then nobody else is affected? What did you? Basically, what do you do? You gotta.
I didn't see any like where it was like
She's like-
clustering of like a family. I mean,
Okay.
like, we have,
No, I just didn't know. I didn't
Yeah.
know if it was.
yeah, no, I didn't see any.
Austin and Tyler are right that you can have a predisposition for it that might increase your chances of developing it, but that also implies that there is a genetic aspect to the predisposition. So if that were the case, you would maybe see it a little bit run in families.
I would assume it could have possibly ethnic predisposition, like Crohn's, but it's not anything I.
Gotcha. Okay, all right. You can continue on.
That's all we have.
Okay, what's up next?
I'll say I'll hop back over to the general, whatever it is. All right, and this is why we kind of hesitated your question about the kids, because that's going to come into big time player for our, because of the circumstances we put under for our patient to be under.
Okay, so we kind of already walked through this, but again, 35-year-old woman, first presented 6 months ago for self-diagnosed pregnancy issues. She's having weakness. She gets exhausted quickly. No signs of ptosis yet, but again, we couldn't really get that fully on exam. It's just a little bit irritable and uncompliant. Baby's health wasn't at risk, so we're going to let her go back to normal life. The birth of the child, though, did provide evidence that the mother has MG, so I think that plays into what Tyler wants to talk about. The patient's current visit is 3 months post-parturition. She's saying that the weakness has pretty much stayed at the same level as during her pregnancy, so it's kind of been a steady, this disease progress so far. AChR receptor antibodies test was performed. It was positive at the time of birth for the baby, and the mother does seem to be suffering more from her previous complaints since her first visit. Its blood tests should prove that the mother has MG-to-do antibodies against acetylcholine receptors.
Why did you guys pick the patient to be 35? Because online it says that it's more common for women who are younger than 40 versus men who are older than 60. Like, did you guys come across that?
So yes, it's generally for when it manifests. It's interesting with myasthenia gravis in that when you have a manifest, like if I have something like Crohn's, it's going to be immediately noted by the person. They're getting diarrhea, they're having bloating, like all that kind of stuff. With myasthenia gravis, it can be a very, very slight or minimal invasive in terms of into your normal life. You're not going to notice it at first a lot of times. And so that's why we picked her to be 35, is because at that point, she might have had it in the past. It might have been something that she's consensusly seen, but as you saw, she refused testing when she had that baby and 3 months.
Yeah, let's say, and she's pregnant. So that's a really interesting confounding symptom, because if she was pregnant, number one, you're going to be extremely fatigued all the time. So you're totally spent out. And then after you give birth, you have a baby, you're going to be tired for 18 years. Okay, so like, I mean, it's a really interesting, potentially related or non-related issue, because in one aspect you could say, well, it's totally not related, but in the other aspect, what happens in order for a woman to get pregnant? Her immune system has to be suppressed, and then after she gives birth, it actually is going to rebound back to normal. And so there's a lot of fluctuation, whether it's decreased or increased, in a woman's, a mother's immune system before and after birth, that make it really interesting. So
That's the reason
it could be linked, and it might not be linked, and they might never know. But it definitely would cover up some of the symptoms and or allow the woman to explain it off. So it's
that's
really
part of the reason we
interesting.
pick 35 as well, is because with the pregnancy, that allows for a lot of exacerbation where you might not even see it.
Sure. Something we came across was that in pregnant women that might have myasthenia gravis, the symptoms actually got worse, to the worst point overall around the second trimester. So maybe playing into this.
Okay. So before I start from 2 on, I just want to say, so like imagine that you're experiencing general muscle weakness as you go through activity. So anytime that you do almost anything, you're gonna have muscle weakness, like generally. So it starts off with the eyes. It's the place that is most commonly initiated, but overall, anything that you do is going to cause weakness. So for this patient, she said she's been having trouble breathing. That's a little bit more of a serious indicator. If I try to do anything too long, I just get really tired. So the way I think about this is I think about just the acetylcholine in the synaptic space just not being there, not binding to receptors. Things just the in-play potential is not being activated, the muscle's failing. How did the problem start, and when was the patient last well? She noticed she was tired when she was pregnant, but she kind of attributed that to being pregnant, which is a very normal assumption, as we just talked about. Physical activity generally makes it worse, and so this is kind of one of those umbrella symptoms that makes it a little bit hard to figure out exactly what's going on, but it's important for the disease, the understanding of the disease as a whole. Anytime she drinks, she gets really weak and tired.
So let me ask you this. Why would someone with MG, why would physical activity make it worse? They potentially get worn out more quickly and have to have a time of recovery in between bouts of exertion. Like explain it mechanistically. Why would that?
So, well, as a
and anybody, you not just you don't
sure.
We have that in the one.
Well, don't just say it right now. We'll go over this.
So
when
you have somebody and you're having constant activity, so let's say I have somebody's arm and I keep telling them just bend it. They're releasing activity at that particular neuromuscular junction for the muscle they're
releasing
using.
What? Not activity.
Well, a nerve impulse is traveling down the particular nerve, accessing that particular neuromuscular junction.
So so you're releasing acetylcholine from the neuron into the synaptic cleft.
As you continue to send that electrical impulse and release that, you don't have just the infinite number of vesicles filled with acetylcholine that you can release into that junction. You have a limited number. If you also have a limited number of the acetylcholine receptors, eventually it's going to get broken down by acetylcholine esterase. And so while those first 2-3 times it could be very easy to cause that contraction, it can become more and more and more difficult as you don't have the acetylcholine to release into that cleft.
Is it an acetylcholine issue or is it an acetylcholine receptor issue?
It's primarily a receptor issue, but so this is kind of one thing that I'd put into the issues is that you have this normal contributing mechanism to this particular instantaneous problem of muscle weakness, which is you're depleting your acetylcholine. But primarily in the disease, you have acetylcholine receptor dysfunction. So you're not just having like decreased binding overall, but then you're depleting the acetylcholine that can bind, and so it's kind of too.
Are you depleting the acetylcholine?
Yes.
Per se, the volume of acetylcholine?
Yes. Yes, 100%.
Are you?
You release less acetylcholine upon direct stimuli of the same neuromuscular junction. The amount of acetylcholine cannot be recycled and or resequestered in enough time to allow for it to release the same mass amount that it's.
So what, so say if you are, let's go on that path, if it is the acetylcholine that you are, that's an issue,
it's more.
What part does the receptor, which you went over in your intro, with the antibodies binding to the receptor, what does that, what role does that play?
Because normally in our muscles, we have such an overabundance of redundancy allowed in those neuromuscular junctions, you don't have that redundancy of the receptors anymore. So it is much more noticeable that you aren't able to bind as much of that acetylcholine to generate those in-plate potentials that will generate the action potential of the muscle.
Okay.
Okay, so relieving factors, sitting down, relaxing, not doing anything. That would be great. Yeah. So her eyes droop a lot. She can't talk easily anymore. This is generally indicating a little bit more severe progression. Over time, it's just more of a steady progression of getting worse, and particularly the symptoms that started off earlier, the ones that are worse over, at any slot in time that you're going to take out like a cross section, it's ones that she initially noticed first are going to be the worst.
And you got to keep in mind, she said that her symptoms stayed the same after ending the pregnancy, having the birth. And if that's the case, she's been getting better in terms of recovering from the pregnancy. So that means the symptoms themselves are getting worse to accommodate where even though she's getting better, she's still just as tired.
All right, so yeah, more just generalized weakness. She can still do easy things. She can still go out, but anytime she's experiencing elevated physical activity, whether that's walking, whether it's talking too long, or even looking around too long, if she's doing anything that involves muscular movement, it's going to take her energy away. It's going to deplete her ability to do those types of activities. So the patient does not have a very pertinent history previous to 6 months previous to her visit. No major surgeries, no major symptoms out of the ordinary prior to that. She was an athlete in college, but claims to slowly put on weight after graduation. Weight is carried in the thighs and breasts, so while she's borderline obese, she does not appear to have unhealthy bodily composition. So to go through her exams, so we have these general findings. Nothing here is really out of whack, except if you notice in red, the respiratory rate, 12 a minute, that's kind of low. I'd say that's an indicator that she's having a hard time breathing, and she's not compensating for it yet with, I don't know the word for it, but increased weak breaths. I think Julia, I think you used that word earlier.
What's the opposite of tachypnea?
Well, that's what I think tachypnea. That was what I was going to use.
Okay,
So like
okay.
so this is not tachypnea, but
Yeah.
sometimes when you get into severe respiratory cases, you actually do see that because they literally are just trying to generate enough breath to survive at any given moment. We're not quite there yet. It's good, but just wanted to note that. Cardiovascular exam, no, nothing out of normal here. Chest exam, breathing is somewhat labored. Breath sounds were heard, but a little bit weak bilaterally. So something that you might want to pay attention to here, I should have highlighted this in red, but the sensory reflexes and the tendon reflexes are normal. However, what we do need to pay attention to is something called the sustained upgaze test, which results in fatigable ptosis at 90 seconds. So most people should be able to do this for about 120, 150, somewhere around there before they have, well, really they wouldn't have any problems at all. But what that tells you is that somebody who has kind of like an initial diagnosis of MG might be able to pull it out to the very end of that range of time and then initiate. But a normal patient would never have that problem. So the fact that she's having it at 90 seconds means that she's already getting worse. Sustained abduction maneuvers, so I mean, she's holding her shoulders out like this. I think that's a little bit more of a taxing activity anyway, but again, most people can do this and not have any problems for an extended period of time. So all these tests serve to show that muscle weakness is initiated at a much more rapid rate than usual in a normal patient.
Yeah, what's up?
Would this target like muscarinic receptors, anything that takes acetylcholine, or just the neuromuscular junction?
So my best understanding is that it's particulate in the neuromuscular junction.
And just to clarify, it is mainly a receptor issue.
Right.
It's the antibodies that receptor, so it's where you do have those acetylcholine receptors, which is what we talked about this, the neuromuscular junctions that you'll see the largest issues with. Now let me ask you this: why do we? So yeah, you can do the other tests, right? Did you go over the eye test?
Yeah, the upward gaze.
Right. So why would that test potentially tell you more, or be one of the first tests that you would do, or one of the first symptoms that would present in an MG patient? Why look at the eyes or the eyelids as opposed to a leg or a?
Because there's muscles that it's not as strong of a muscle as a
Perhaps it's digital activation.
They're both small in terms of not taking much to wear out. They are very easily fatigable because they're constantly used, but they're not used in strenuous situations. If you have someone look up and hold that, you're constantly having to stimulate that same neuromuscular junction and keeping that gaze.
It's less with the fatigability and more with the fact that those neuromuscular junctions are activating one muscle fiber, right? Whereas with the quad, you're going to be, if you flex that, contract that, you've got a ton of muscle fiber there. You can even do like strength of contraction.
So less redundancy of activation.
Yeah, and so what you're going to see is you're going to see the singular muscle fibers that are integrated with really one main neuron be affected first, simply because there's just one there to make the movement. If you take out that one there or affect that one there, it's going to be a lot more noticeable than if you affect one muscle fiber in the quad or one muscle fiber in the a larger muscle.
Okay, so some of our general tests that we did was the arterial blood gases, and all those were pretty normal except her O2 sats were a little low, and then as she was speaking, they dropped even lower. That was kind of like a normal thing that people should not, their O2 sats should not drop in response to that, and hers did. Her MUSK, which is a good sign of how severe the problem is, was high, and her anti-acetylcholine receptor antibodies were all high. And each of these, the binding, blocking, and modulating, are the different types of different mechanisms that the disease can occur through. And so you test for each of those different antibodies, and all of hers were high. You should normally be none, slight, very undetectable levels.
Keep in mind just how specific antibodies are. They are in almost direct correlation to a particular antigen. So if she has 3 different types of mechanisms occurring here, that means she has multiple antibodies or multiple diseased lymphocytes that are creating separate antibodies for different parts of that acetylcholine receptor.
All of her other levels were normal, and all her CDC. So we did all that is normal. The CDC, we saw an increase in the lymphocytes and the eosinophils, and as far as the white blood cell count, and that's just the response to the increased antibodies and the disease. And then as far as her hemoglobin, hematocrit, everything looked normal.
An interesting correlation to be made with this disease is that increased eosinophils was a huge marker in people with myasthenia gravis. So they took the set of people with it, and almost all of them had an increase in their eosinophil level. However, they do not know the mechanism that the eosinophils are actually causing in the patient. They don't know what the eosinophils function is in myasthenia gravis, but there was a huge correlation of them being high in myasthenia gravis patients.
Some of the other tests they did, and just the basic observation of the patient, was that she had the bilateral ptosis, which both of her eyelids were drooping, and that she had limits in how far her eyes could move. That was just basically your doctor doing his pen side to side, and you having to move your eyes to each side, and she was limited on that. All of her other reflexes and muscle senses, and her, she was pretty with it. She wasn't having any confusion or anything like that. After he made her walk up and down the hallway, and
her gait changed, her walk changed after only 100 meters that she walked, and that was kind of just a sign that her leg muscles were getting weaker. And he made her just do as many squats as she could to see her muscle weakness with that, and so she could do 5 squats before she needed to use her hands to stand up. Yeah.
Slightly outside the scope, but I wanted to know if you guys came across. To me, this looks characteristically almost like a stroke. So I wanted to see if you all came across anything where it was not bilateral and you only had it on one side of the body, or would it always be bilateral? Do you
Before you answer that, it's a great question just to tag on to that, not another question, but one of the first things as a clinician that you would want to rule out if you have someone coming in with any type of drooping, especially facial features, is like that, like time is money when it comes to stroke. So getting them in and doing a rapid, blood test to look at, what is it, a D-dimer test is what you would really want to look for looking at. That can be done relatively quickly. In fact,
Right.
I know someone who I had to take in who thought they were having a stroke. It turned out to be what's called a transient ischemic attack. It was a stroke. It's a tiny stroke that was self-resolved, basically. But that's a good point. So that, not that you miss anything, but like just as general clinicians, like you all need to know that is a hallmark sign. You've got to go out first. But
That's a good, I feel like as I was researching, it was more common to see just the one, like unilateral ptosis, but because hers had just the severity had increased so much in those 3 months since she had been pregnant, at this point it was affecting both
That's
eyes.
something huge to note in her case specifically, because she refused testing on the actual birth and at that previous visit. But the baby was tested and proved positive for the acetylcholine receptors. That tells us they aren't coming from the baby. They have to be coming from the mother. So that gave us a huge.
Okay. Say that again. The what?
The baby tested positive for acetylcholine receptor antibodies.
Yeah.
Okay, and then so she looks tired, but I mean she's a new mom, so and everything else with that looks positive. The edrophonium / penicillin test, Abby will let you guys know what that is. She'll explain that for you in just a little while, but basically that it's an injection and it's gonna see if they can use these chemicals to improve the ptosis at all. And if you do have an improvement that is greater than 2 millimeters, then that is a positive test result. So and her range of eye movements increased, as well as she could walk for a longer distance, and she could do more squats before she needed to use her arms to help her. We did an EMG, which basically we stimulated different nerves and saw and to look at how if the amplitude of the action potential was going to decrease upon stimulation of those nerves, and it did. There was a greater than 10% reduction, and you can see from these graphs that just with each amplitude got shorter and shorter with each muscle that we tested. And then we did the CT scan to rule out to rule out thymoma or even hyperplasia, because sometimes you can have like something that they think is a thymoma, but really it's just the hyperplasia of the thymus gland. It's just an enlargement. It's not actual tumor. Pulmonary functioning test showed that she was having a hard time breathing and that her respiratory rate was increased slightly, but that everything else with the pulmonary function test looked good. And the ice pack test, which is also gonna, Abby will talk to you guys about, but it also showed an improvement in the ptosis that was greater than 2 millimeters, and she actually improved both her eyes 5 millimeters, which was a surefire indicator of myasthenia gravis.
All right. So here's the meat and potatoes. This is all the reasons this stuff happens in the body. So myasthenia gravis is an autoimmune disease. We covered that. Skeletal muscle weakness is the most prominent indicator of this disease. You see it mostly in the facial muscles or in the smaller group muscles where they don't have as many fibers innervated by that particular nerve. There's not a 100% correlation with the weakness,
with a particular antibody to this disease. So while, yes, we talk about the acetylcholine receptors, yes, we talk about MuSK antibodies, those antibodies, you can have neither of the antibodies and still have it called myasthenia gravis. There's kind of like a mystery layer of this disease that they haven't been able to classify. They're calling it myasthenia gravis. It's kind of sketchy whether it's really myasthenia gravis in the case when you have that muscle weakness without those particular antibodies inhibiting you somehow at the neuromuscular junction. All autoimmune diseases are chronic. They are going to be slowly worsening. It's a matter of what speed they are worsening at. Someone with myasthenia gravis has a completely likelihood that they'll have the diagnosis and they'll be able to continue their life by completely normal with maybe a pill in the morning as a slight immunosuppressant or a slight, like the neostigmine test. But we're going to dig into that a little later.
Oh, go back up, I'm sorry.
Right.
So what was that disclaimer you said with the correlation? So you can have, like you said, there are some cases of myasthenia gravis that you can have without it being autoimmune.
Well, without presence of the anti-acetylcholine receptor antibody.
And what percentage of those did they say? Because I would say it would have to be the minority. Because if you look at like myasthenia gravis, and the hallmark factor is that you've got your body, your immune system is attacking those acetylcholine receptors.
It's also really high in like false negative tests with those antibodies. So I guess a follow-up test would probably be like another round of that blood test would probably be a smart thing to do if you do given it.
So what would that tell you in terms of if you didn't see an increased antibody to the acetylcholine receptor, like what for those cases, or where have you read that or got that stat? What other explanation did they offer for the symptoms that were there?
They just said it happened.
They just said,
yeah.
Okay.
They said it looks like myasthenia gravis. We can't find antibodies, but everything else looks exactly.
So I wonder if it's like, okay, instead of getting that, what do you think would potentially be your physiologically, mechanistically focused brains now? What do you think would be a mechanism for that without antibodies?
One thing that comes to mind is perhaps some sort of pathology related to acetylcholine release.
Wouldn't that affect though?
Where all of the snare
that would. Well, sorry.
I said, where all are the snare proteins involved in the body would be my immediate question with that. Because if you could narrow it down to the snare proteins that does release, that's great.
So yeah, so maybe with the acetylcholine itself, but generally with symptoms like myasthenia gravis, regardless of whether you see antibodies, my money would be on as similar an instance, which would be with the receptor. What if, perhaps, it's just what if, because myasthenia gravis, you have antibodies attacking the receptor, which means you have a higher rate of receptor turnover to get rid of those because you have non-functional receptors, and that higher rate of turnover eventually causes a loss in receptor number, which is the hallmark issue with myasthenia gravis. What if you had a non-immune related issue with the turnover rate of those acetylcholine receptors?
If the genes that cause
perhaps
turnover,
what if you had a
an
gene that either influenced or maybe it wasn't, maybe not necessarily turnover, but what if it was just maybe one codon off just enough to where it caused 10% of your acetylcholine receptors to be just enough abnormal to where the ligand, the acetylcholine, doesn't bind to it, but it would cause a problem. Yeah, perhaps. And so my money would be on that because there isn't. I actually looked it up after we said there actually from what I've seen there actually isn't any indication that acetylcholine there's a problem with acetylcholine release with myasthenia gravis or even acetylcholine number. And with the ICE test, which I think Avi said to get into, that's a fascinating way to kind of show that it really is about the receptor. So yeah, go ahead. I just wanted to kind of like use some brain churning there to try to come up with some mechanisms.
In case it came across differently when I was earlier speaking. I'm not saying that decrement in the acetylcholine is any kind of pathology. We naturally have less acetylcholine to release if we're constantly stimulating.
Oh, right,
So
yeah.
like,
I'll
it's
agree
more,
I'll
it's
agree
more
with that.
noticeable.
I thought you were saying that they have in totality before any release.
Oh, no,
less
no.
acetylcholine.
No,
Okay,
no.
we're on the same page then. But I was like, wait a minute.
It just-
this is definitely a receptor.
It doesn't have as many places to react, so like the decrementing amounts that is released just for the
And
sake of.
that's true, and that's one of the, like you said, I really like you said, mystery of it, because muscle fatigue, like why should our muscles get fatigued? And that is one of the proposed, that's one of the proposed mechanisms. Question or comment? Oh, you're doing your
That is
car?
working, yeah.
That's one of the proposed mechanisms of muscle fatigue, is that you either have, you slowly are, depleting your stores of acetylcholine faster than you can recycle it, and or, actually that one I think is the main one. It's not even having to do with the receptor really. The receptors.
Because it'll react if it reacts.
Yeah, there's one thing that helps me think about it. It's the hyper, I can't remember what we call it, but it's when you get an inflated potential and you want a huge release of neurotransmitters so that you get one muscle action potential. I can't remember what the term is for that.
And that might be hyperpolarization. Is that weird?
No, it's basically you get a huge.
It's the redundancy. It's the safety factor.
Well, yeah. So it's like basically as you use. That's kind of why I was talking about this disease mechanism of the receptor going bad, and then instantaneously in that moment you're kind of running out of acetylcholine to activate the receptors. It will.
You're not talking about like inhibitory potential and
No,
excitatory
it's like the excessive action potential that's generated in order that you actually get the muscle, the inflate potential to fire. It's a term that it's in Stremmel's notes. It's one we should.
Dr. Stremmel. I don't mean to harp on that, but
No, you're right.
You gotta give credit where credit's due. I mean, it took me freaking 5.5 years of my life slaving away to earn that stupid 3 letters at the end of my name. So, but anyway, yeah. So, but I hear what you're saying. So that is what you're saying is looking into muscle fatigue as well.
Yeah,
Might be an explanation of it.
And going back to when you're talking about
Super
why
optimal.
single nerve fiber and like that, that lack of redundancy of activation is what
Right.
causes this particular muscle to fail. Just overall, in the moment though, when the muscle's being activated, that acetylcholine depletion is contributing to the symptom, but not causing the disease itself.
Are you talking about when you reference the supramaximal and supraoptimal nerve stimuli, in which it correlates with all firing, literally everything at once?
There's a short little term. I'll have to think of it.
Okay.
All right, continue on. Avi, did you want to?
So,
No.
Oh no, I was like, no, not me.
Caleb?
Whoever's going through, yeah, keep going.
Oh yeah, sure.
Pictures.
We'll zoom in on the picture. in a
Oh, I
second.
thought it was just because it's more, I didn't know who's part of it.
All right, go ahead. Continue on.
Okay, so let's go through the activation at the neuromuscular junction. So we have an influx of
I'm sorry,
calcium.
pitch to zoom. I got it. There we go. Thank you. All right, continue on.
So we've got an influx of calcium that's going to cause a release of acetylcholine.
Yeah.
So calcium.
Sorry. I even help students who are in nurse practitioner programs, and this is one of the big things that we talk about that, and I hammer home is so talk me through. You don't have to like read everything, but just briefly talk me through every mechanism, like everything that happens when that when that action potential travels down to the terminal bouton.
So you have the action potential traveling down the neuron, and as that causes opening of the calcium, the voltage-gated calcium channels, which causes an influx of calcium, which start to bind to the snare proteins, and then the snare
synaptotagmins in there too, I believe. Yeah. Like the calcium binds onto synaptotagmin
of the vesicles.
Yes.
Of acetylcholine, which each vesicle actually contains the exact amount, the same amount of acetylcholine in each vesicle, called a quanta.
Oh, okay.
And then that is going to cause what?
Yeah, so the vesicles are going to get pulled down towards the end of the.
Migrate towards
They're going to migrate towards the synapse, and then the vesicles will actually fuse with the membrane and get released.
Exactly. Okay,
Yes.
release their acetylcholine. Good.
So
I'm getting excited. Even like, isn't that funny?
Very exciting.
So you have your acetylcholine released.
Okay.
Once your acetylcholine release is traveling through the synapse, binds to the receptors.
Binds to what receptors?
The acetylcholine receptors.
Which are?
on the
Ligand gated ion channel.
What ion channel? Ligand gated sodium channel. Very
cation
good.
ion. Oh,
I think it's sodium.
I thought it was very, very specific that in the neuromuscular junction it was just cations, that it would accept any particular
It's the sodium channel.
Okay.
So it's most common with sodium channels when I
Ligand gated sodium channels.
ligand gated sodium channels. Immediately once the acetylcholine is in the synaptic cleft, it's going to begin to be broken down by acetylcholine esterase. Only some of it actually makes it to the receptor. So that's one thing to keep in mind, which is actually, if we can go back to the ice pack test, acetylcholine esterase activity is decreased, and as a result of that, you actually get improved symptoms. So again, going back to redundancy, and this is what I'm particularly talking about with that term. There's 4 to 12 times the amount of acetylcholine receptors compared to what is needed, and that's because we need that excessive, quote unquote, activation or excessive release, so that we can actually just get one muscle impulse.
So it's like a safety threshold.
Well,
Right. Yeah.
yeah.
It's safety. It's
as Dr. Schimmel phrases it, if you're running from the saber-toothed tiger, you want to be able to run.
yeah. So we've gone through that.
What was it? Are you guys remembering Dr. Schimmel's or?
Saber-toothed tiger came up all the time.
You say it all the time.
I use a bear whenever I'm talking about it. The bear walks in the room. All right, continue on. So that was a good explanation.
Okay. So we have the ions traveling through. We get a muscle action potential or end plate potential. Muscle will fire. So overall, MG will cause a decrease in the availability and the number of acetylcholine receptors, which is why we have a problem generating that end plate potential.
Yep.
Overall, the best way to think about this for me is that it's a fatigable weakness, just meaning the more you use it, the worse it gets.
But it recovers.
It does recover. It
When
does.
you have a time, that's an extra.
And that's why the
yeah.
resting helps.
Yes.
Yeah.
Frequent rest. Okay. Okay, so now continue on. All right, you go.
All right, so that's me. So these are kind of the mechanisms of what possible things are happening in the body that actually causing this disease. So autoantibodies generally are formed when the B cells developing in the bone marrow or the T cells developing in the thymus are self-reactive. Normally, anergy and or known as negative selection, they are two different things, but for this sake of explanation, I'm going to use them together. That is going to allow for those T cells and B cells that are reactive to self to not get the positive promoters and not develop, not be able to mature, not be able to function as an antibody creation and or lymphocytic like macrophage and such. It will not allow it to attack self. It's going to stop that development.
Which one of those creates antibodies?
B cells. B cells is the antibodies,
Right.
but
B
T cells and
right.
other stuff,
Can
that's
activate,
more
right?
of,
They can actually activate it, right?
Yes.
So they have B cells turning into plasma cells, and those plasma cells are actually the antibody factories that are going to
and in your lymph nodes, the T cells have to actually have noted something, go back and activate and say, hey, B cell, make me some antibodies to this.
Which is where you've got the, that's where you have your, geez, I'm blanking on the name. You've got your, type 1 and type 2. What am I thinking of? It's the pedestal, it's the protein pedestal that holds out the MHC
complex.
Major histocompatibility complexes that that those
And one is the
cells
self-identifier, and then two is the
2 is on CD4 plus helper T cells.
Two are going to be activating cytotoxic, helper, memory, and another
I think 1 is cytotoxic and 2 is helper.
One might be cytotoxic and memory. Both of them do memory.
Yeah.
And then 2 is memory, helper. There's another one. What's it? Cytotoxic. Suppressive. Regulatory. All right. Continue on.
So if you don't have that negative selection or the pushing back of those, that would allow them for development. So we know there's some kind of issue with the actual development of her lymphocytes. Secondarily, the next thing you're going to see in this disease is antibodies to the nicotinic acetylcholine receptors themselves. We beat that into dust on that previous slide of kind of like where it's hitting and whatnot. This is an example of binding to an active site. So this is where the acetylcholine would normally bind, and instead that antibody is blocking that site. That's considered binding of the three. So binding, blocking, and modulating. Blocking is the sides. So where you see that cross cross linking, and the antibodies, like think about, you have two sites here, so one might bind to this side and one might bind to the one next door, and that's going to increase the cross linking and actually clustering them together. Then you see the modulating. Modulating is using that cross linking and causing the internalization of them and recycling of those particular ones. Lymphocytes, what do they do? So macrophages that eat things in our body, they phagocytose foreign pathogens and or things that have the antibodies bound to the outside that we recognize as foreign. They come from the progenitor cell that is for most of our immune cells, not the TMB.
I'm not talking about the hemocytoblast. I'm talking about macrophages. What are they? So real simple, macrophages are monocytes that are in the tissue.
Okay.
So once monocytes are in the blood, and once they are attracted via cytokines, inflammation, sort of tissue damage.
They can be called as activated monocytes.
Right. So they're monocytes that have been migrated into the tissue and are now active in the tissue. So, they use chemotactic cytokines, chemokines, stuff like that.
So early on in myasthenia gravis, they're going to be more of the antigen presenting cells for the T and B cells to activate them. And then as they've also been shown to have a play in the amount of inflammation at the neuromuscular junction, and that can exacerbate symptoms.
Does anybody know what an ABC is?
ABC.
Antigen presenting cell. Does everybody know? Everybody good? You guys got it? Zach, what is it real quick? You know what it is?
So antigen cell will be it expresses the
like explain it to your mama, like
So are we talking about the cells that then go in and express antigen to recruit the helper T cells?
Right. So in a nutshell, if I'm explaining it to my mom, that's exactly right. So in a nutshell, you have cells that are going to detect and find pathogens. They're going to eat it up. Well, no, they're going to engulf it. They're going to chop it up into a bunch of little pieces. Take those little pieces and display them on their own cell surface, hence antigen presenting cell, so that B cells and other T cells can come along. B cells can come along, get activated, make a copy, analyze that to make an antibody to that specific antigen, and then also T cells will come along and get further activated and initiate a cascade of activation throughout the immune system.
And that's why we have so many rotating T cells and B cells. They can't change their receptors to match an antigen. We have tons of different T cells and B cells with tons of different receptors, and the one that matches is the one that is promoted to proliferate and divide.
Also, I'll point out that every cell in your body has the ability to be an antigen-presenting cell because they have MHC1 except for red blood cells. A fun fact of the day.
Eosinophils. We don't know what they did. Not for this disease in particular. Like there was no proposed mechanism.
I don't know what eosinophils
We do not know what eosinophils.
So what
contribute
why do
to
you
this
have those?
particular disease?
What do they do? Like generally, like if a patient asks you what does an eosinophil do, and you would say what? In a nutshell.
I know they're elevated. You've got high allergies.
So allergens, but also parasites. So whereas today we think, oh my gosh, parasites. No, it used to be a very common thing. And I think it's actually, there's an alarmingly high statistic of individuals that have worms in their, like of Americans. Like I think it's like 20% of Americans have intestinal worms, like parasitic worms, and they don't know it. Isn't that alarmingly high? I mean, it's a crazy, maybe it's not as high as 20, but it's definitely high. Anyway, it's very, very common in third world countries, and they kind of live in, once again, it's like a symbiotic thing. So that's mainly, eosinophils are they do have some with allergic reaction, but I think the majority of them
the way that we push down our allergies and use all those drugs can actually inhibit some of the eosinophil potential action. Cool. So it's double dignitary if you have
NKCs.
So NKCs, these are the ones that would actually kill off the cells that are presenting those acetylcholine receptors. That's their mechanism in this particular
disease. These are like the gangsters of the immune system.
Yep. They got the Tommy guns and going around killing.
It's like hashtag no.
Oh. No.
And so just to clarify, there are two types of NKC cells. There's the NKCs, natural killer cells of the innate immune system, which are kind of just default always on and are just roaming around and finding and killing pathogens, even some of our normal cells. Those are just normal. And then you have the adaptive immune system, natural killer T lymphocyte cells, which have to be activated. And those fun fact of the day, another fun fact, is those can actually turn into other type of cells, including the helper T cells. So these T cells have some sort of ability to sort of transform and take on the roles of other cells. Let's get this guy. Sorry, go ahead.
So one of the
body language again, she's like
another mechanism is the MuSK antibodies. Those are just another, kind of like you attack the acetylcholine receptor. You can also have it attack MuSK and it will present in the same manner. Muscle weakness post-exercise. This is where we dug in the ground earlier. There's less acetylcholine over time if you constant stimulation release at the neuromuscular junction. Therefore, you're going to see them be tired, more tired than normal after the exercise. Thymic hyperplasia and or the thymoma kind of play in together. You're going to see an increased size and activity at the thymus if you have a person with myasthenia gravis. You see this in many, many, many autoimmune diseases or anytime you're fighting an infection. Usually, however, post-puberty, entering adulthood, most of the thymus is generally replaced with fatty tissues. That doesn't happen if a person has myasthenia gravis because it keeps it so active.
Why? Like, what's going on in that thymus?
The thymus is where you see the maturation of the T cells, and that's why the activity is so high.
I say boot camp for the T cells. Right. Where do B cells get their boot camp?
Bone marrow.
Oh, there. They learn what's called renal competency, not to shoot themselves in the foot. Abby.
All right. So I'm going to talk about, these are the general symptoms of myasthenia gravis. We talked about ptosis, drooping of one or both eyelids. You can also have diplopia, which is where you have blurred or double vision, and that's due to, again, the weakness of the muscles and the ocular eye muscles. And you can also have a change in facial expression due to facial muscle weakness, like as we saw in those pictures where like one eye will look like it's raised, but that's the normal eye. It's just that the ptosis eye is very droopy, and that could also have like facial droopiness on the side. Are you raising it? Oh, yeah. You can also have difficulty swallowing, shortness of breath due to muscles not being as active as they're supposed to, so the person struggles with breathing and talking, impaired speech, weakness in arms, hands, fingers, so extremities, again, muscle weakness. Here's some general diagnostic tests. There's the physical and neurological examination that's done as soon as the patient comes in. This is where we check for the patient's history, what are some compounding factors that might that might relate to myasthenia gravis or other types of diseases. So here we were trying to look for abnormal neurological and muscular control and activity.
We want to know what is baseline.
Yeah. So what are some values that differ from the baseline? And then next we have the endrophonium test, and this is where we have injections of endrophonium chloride to relieve weakness in people with myasthenia gravis. And what happens is that the drug is going to block the breakdown of acetylcholine, so it's going to block acetylcholine esterase, and therefore we should see a temporary increase in the levels of acetylcholine, and we should see more normal functioning. So how do presenting values differ from normal physiological values? So if ptosis stops and ocular muscle strength improves, again, greater than 2 millimeters compared to the baseline. For the blood test.
I'm sorry, go back up. You said 2 millimeters?
That's the general significant finding. If it's greater than 2 millimeters.
Yeah. And blood test is to just test for levels of acetylcholine receptor antibodies in the blood. We're searching for evidence of high levels of those, again, acetylcholine receptor antibodies. Some possible issues we have, if there's the anti-MuSK antibody that is found, and that's found in approximately half of individuals with myasthenia gravis. Those that have it also initially don't have acetylcholine receptor antibodies. And what happens is that in some other patients, they neither have the antibody, the anti-MuSK antibody, nor the acetylcholine receptor antibody present. And this is where we have the negative antibody telling us that there isn't the antibody itself.
And that's when you want to kind of be careful of, is this myasthenia gravis at that point? Like, is that what it is? But
do they still have the increased platelet and increased white blood cell count I'm curious with these patients, you may not know the answer, but I'm wondering if there's an antibody that still targets the acetylcholine receptor that maybe we just don't know about. Maybe that we don't have a test to test for, or I wonder if everything else except finding the antibody points to that there is an antibody.
We'd be able to pull an antibody out of the bloodstream.
Right, but
so
we're talking hundreds of thousands, maybe tens of thousands of antibodies, right?
Yeah.
So we can pull out all of them, but when we test for them, when we run them on an ELISA, right, or something like that, we have to know what binds to a specific antibody. So we can rule out certain antibodies, but we can't rule out all. And then that's why I asked the question is there still an immunological response to these patients there? Yeah, and that's fine. It's just food for thought. Okay. Everybody's like, hurry up. Too much donuts and coffee. I'm excited about it. This is physiology, yo.
Yeah.
Okay, this was before I was talking about earlier. I explained them, but this is a picture of it. So that first one is where we have the complement binding activation, and that's where it can activate the T cells that allow for the membrane attack complex to be developed. Antigen modulation, I told you, internalization of those receptors, and then the acetylcholine blocking, literally being like, you ain't binding here because I did already.
Okay. So this one is the electrodiagnostics. So this is where we have repetitive nerve stimulation to extremities of the body to test to see if the body responds to those electrical impulses. And what we're identifying is the response time and strength of that nerve stimulation. So if there's going to be a delayed time in response, like there might either not be a response at all, or it might be very, very delayed. So that could indicate myasthenia gravis.
And that top line emphasizes what you talked about earlier, the single fiber myoelectrogram. That's your best noter for this disease, because you could simulate that single fiber like the eyes. Come on.
So for the EMG, what you're saying is from a normal patient versus one with MG, you're going to see a different timing of that stimulus. What about the shape and amplitude?
So once you have an active potential, it's
the same. The amplitudes are going to be the same.
So you're not going to. Okay, so you will or you won't? Okay, you won't.
Yeah.
You won't.
It's all or no.
You'll see a decrease in the strength, but that's because of the amount it's able to stimulate it with. It's not because it's like a lower amplitude actual potential. That's just not a thing.
Good question. Continue on.
So yes, so we have the diagnostic imaging. So either with the CT scan or MRI scan, we are looking for the presence of a thymoma, which we talked about being a tumor, usually around the thymus. So again, we're trying to see if there's presence. So if there's no presence, that's a good thing. Or like if there is, then we need to figure out what's wrong. Then pulmonary function testing, measuring breathing strength to help predict whether respiration may fail and lead to myasthenic crisis. So we are searching for what we're looking for is there anything in the patient's history that would make the appearance of breathing problem like a false positive in terms of myasthenia gravis. Like there might be other things involved and it might not be because of myasthenia gravis. And the ICE-PAC test is a popular test that's used. Again, this is kind of looking, this is a sensitive test to diagnose MG and ptosis due to it. And what happens is that you place an ice pack above the affected upper eyelid of the one suffering from ptosis for 2 to 5 minutes. And the test results are positive for MG if you see improvement from ptosis for, again, more than 2 millimeters. And we do this because how it works, I don't know if the graph is here.
We do have the graph.
Yeah. So how it works is that kind of thinking of like enzyme function. So because you have such a low temperature working with an ice pack, what that's going to do is that it's going to decrease activity in terms of acetylcholine esterase. And because acetylcholine esterase is responsible for the degradation of acetylcholine, by decreasing activity of acetylcholinesterase, you're going to have more opportunity for acetylcholine to interact with its receptors, and therefore lead to muscle contraction.
Thus, it can hide or mask the fact that you have less receptors just because there's so much more of the acetylcholine available to be in that cleft.
I think that's it.
Those are actual symptoms for our patient in particular. We've dug through those a little bit. Shortness of breath, drooping eyelids, easily fatigued muscles, trouble with speech. Common treatments.
Sure. So in terms of treatments, two of the major, I guess, different categories you use are acetylcholinesterase inhibitors, or ACH inhibitors. And what they do is similar to the ice pack test, but on a systemic scale. Basically, it prevents or slows down the breakdown or hydrolysis of acetylcholine, which can help to compensate for the lack of receptors or for the degradation of receptors. If you've got a higher concentration of available acetylcholine, there's a greater chance that they can interface with the remaining receptors. So we've got two main drugs that seem to be the leading drugs that are prescribed for this: pyridostigmine and neostigmine. Really, just the stigmine class of drugs that kind of do a similar thing. Really, the only notable thing about this is that if you administer neostigmine, you really have to monitor. It's usually an injection administered by the physician. You have to monitor the patient closely right after injection because there could be a development of bradycardia. So in that case, you would also dose with atropine or atropine, and again monitor them after that. Next up, immunosuppressants. And the first one, cyclosporin. I think we mentioned that in the previous case study, but basically, all of these different immunosuppressants affect inflammation or T cell proliferation or development in some way. They're all going to do it in different ways, and there's many more drugs than I have listed here, but that's basically the gist. So for cyclosporin, it blocks the transcription of cytokine genes in activated T cells, which could help prevent activation of B cells, the formation of those antibodies. Azathioprine, it's metabolized to 6-mercaptopurine or 6-MP, which is also used in Crohn's disease as an immunosuppressant. And it's a purine analog, basically blocks DNA replication, again, slows proliferation of T cells, because in this condition, and other autoimmune conditions, they're very rapidly divided to proliferate. Next up, corticosteroids. The main one here is prednisone. It's kind of a generalized first-line steroid that's administered to patients with a variety of inflammatory diseases. It reduces inflammation. It also affects T cells in several different ways. But this one is kind of given for short amounts of time because it has the ability to cause significant side effects like skin thinning, weight gain, many other things, stomach ulcers.
I think that is what was given to some of my kids when they had croup, I believe. So just that chronic, or not chronic, sorry, acute inflammation of the large bronchi that's causing the it happens. It works so fast.
Yeah.
Like incredible.
Because if you back that immune system off, but you also have to take into account you're backing their immune system
Right,
off.
and that's
They're
why-
way more impressionable by other bacteria.
Yeah, and often like the actual administration or dosage of these medications could be, for most patients, maybe 2 weeks max, and then you want to you want to taper on.
Yeah,
taper
this
off.
is usually with croup. It's literally just a one-time dose to get them through the episode. So.
Next, where are we at? Biologics. So this includes things like monoclonal antibodies like eculizumab and several, again, that were mentioned with Crohn's disease. And this particular one is found to be very effective in myasthenia gravis, and it's more of a newer drug. Came out definitely more recent than the rest of them. And this stops the formation or the cleavage of complement C5, and the cleavage of that is necessary to go on down the line and activate that membrane attack complex that Tyler alluded to earlier, and that'll reduce lysis of AChR presenting cells in the neuromuscular junction.
It's the MAC attack. That's what I call it. So the MAC attack attack, membrane attack complex, right?
Yeah. So just an important point about biologics before we move on is that these you have to be really sure you want to give these medications to patients, because as soon as you start a biologic, the patient has a chance of developing anti-drug antibodies against the medication. So if you give the patient this drug and then you stop the drug, there's a pretty good chance that you can't start it again. So it's really something that you want to know and you want to give that drug to the patient before.
And it has to be something where it's not gonna, you need to consider all adverse effects because you only have a one-shot chance with those. And it could even, if it develops an antibody against this one, it could rule out other drugs that are similarly structured.
How often do you see thumectomy? Is that, I guess that's like last stage, like,
Yeah.
like last
Well,
treatment option?
it's not,
It's for chronic severe cases most commonly, and often it's not in every patient that you see a thymoma where thymic hyperplasia that it's definitely going to cause worse.
You only do a thymectomy when you have a thymoma or that chronic hyperplasia?
it has to be of such a degree of severity that it is causing significant change in their
It
lifestyle.
doesn't have to be thymoma, but as we alluded to in the introduction, the different classifications, the fulminating where it's very severe, that you have to do that.
Like where you look at that.
Plasmapheresis is basically filtering of the blood and the plasma, trying to get an antibody out. In our case, it's the acetylcholine receptor antibody, and it's kind of a diagram of how it works. You take the blood out, filter it, keep it.
I mean, he's like, let's rock it.
There's not much more.
Keep going.
IVIG,
I like your face. Keep going.
intravenous immunoglobulin that's collected from donors. And really what this does is these immunoglobulins specifically target the anti-acetylcholine receptor antibodies and stop them from functioning before they can affect the actual receptors in the neuromuscular.
Good job. All right.
We have more, but
How much more do we have?
we have a supplemental in the Friday wrap up.
Okay, so I can look over the Friday wrap up unless you all want to present, do you all want to present that up
I'm
here?
completely okay with being done.
So yeah, why don't we call it right now?
Okay.
What we'll do is, I can, on Thursday, you guys can just finish, just present the Friday wrap up, Wednesday, sorry. So little thing, thank you all so much for being patient with this course and this actual session, and then also on Wednesdays. Brought donuts, coffee, take some with you. Yeah, all right, guys, that's it. Thank you for staying afterward. If you have any questions, comments, let me know, and we'll see you on Wednesday. Good job to both groups. Good job, both groups. Yeah.
And you'll see where I kept mentioning, like, oh, now come on, back the child stuff comes into play.
Good job, folks. Good job. Thank you for staying an hour after. Yeah, sure.
So you mentioned last week about pushing the LinkedIn class program to do.
Yeah. Yeah, you talked to Dr. Shushki, Dr. Joshua, and you'll be able to, they'll.
And we'll just be like research.
I believe so. I think it's because obviously you've done all the schoolwork and book work, so it would really just be doing research for a while. I don't even know the time period, it's not very long. And then you would get a sort of 2 years thesis, thesis master.
That might be better than doing another 2-year master's.
Yes. Yeah.
And then.
Oh,
PhD
yeah,
on top of that.
for sure. For
Always
sure.
been cool.
Stay in school very literally.
Honestly,
Oh,
I'm
I
never
feel
gonna
horrible
graduate.
for making you guys stay afterwards, but I think some people would do that. Great.
We have an option to leave.
That's right. Perhaps. Yes. I mean, let's do, throw the. Yeah, okay, gonna bring these, gonna take those downstairs. Can you grab those for me? Buddy. Let's go to the trash. And then somebody bring that downstairs. Or maybe over there. This way.
Yeah. At 9:30, but there was nobody there.
Oh, yeah.
But it was there. It was
It's very strange. He does this thing all the time. Nobody wants to come. He wants to come. It's showing your picture on the computer.
on the camera.
Oh. Also, we should be able to see the game.